Now we go to the presentation. So this is basically just a brief overview of what we know related to MS in Pakistan और कुछ इसमें recent literature की भी references हैं और बाकी बहुत सारी पुरानी चीजें हैं जो आपके इल्म में है काफी. MS का data in Pakistan is evolving. Even MS data around the globe is evolving. So every time when you review literature, maybe every year you see an increase incidence and prevalence across the globe. Even in South, you have now increased prevalence and incidence in the region, especially literature coming from Africa and from South Asia. Project नहीं हो कम.
प्रेजेंटेशन कौन सी हुई
इस स्लाइड पे इसमें बहुत सारी है ना,
के अंदर?
इसमें से ये वाली प्रोजेक्ट नहीं हो रही ना इस पर.
शेयर वहां से करनी पड़ी, वहां से उस नियम से
कहीं से भी करो करो तो सही
हो जाती है.
प्रेजेंटेशन. अभी तो सारी प्रेजेंटेशन ही है नहीं यहाँ पे.
सीबत है एक अवसर में. यस सर.
वही सारी प्रेजेंटेशन है तो इसी पर ही ना. अभी ये कनेक्ट नहीं है ना डिस्प्ले से एलईडी प्रोजेक्टर से.
बस हम को कहते हैं यार, कल से लगेंगे, कल से लगेंगे. अब बात करो यार, खोलिए सारे प्रेजेंटेशन खोलिए. डेस्कटॉप पे चेक कर, डेस्कटॉप पे रखिए. कहाँ पे पड़ी है मुझे पता. टेक्निकल बनते तो हो ही नहीं इसका, लग रहा है मुझे ऐसा यार. ये क्या है भाई? निकालेगा यूएसबी के अंदर है. हाँ हाँ, कॉपी कर रहा हूँ, मैं निकाल देता हूँ. इधर उसके अंदर है ना. यार वहां से एक्सटेंड तो नहीं करनी थी। ये आ गई ना वासिम, ये आई हुई है ना वैसे प्रेजेंटेशन, ये आ गई है ना मेरे पास वहां से, उनके पास से। तो एचडीएमआई वापस लगा दें, यही है ना प्रेजेंटेशन की? ये तो फोल्डर है मुझे लग रहा है, ये फोल्डर है या क्या है ये?
प्रेजेंटेशन है भाई यार।
नहीं नहीं, ये तो आउट जा रही है उसके ऊपर, ये तो आउट है ना, ये तो इनपुट थी, इसको छोड़ दो। एचडीएमआई आउट तो जा रही है ना, उसको देखो जरा, जा रही है?
नहीं जा रही ना, नहीं ना जाती उससे।
नहीं नहीं, इसका तो काम।
फ्रीक्वेंसी जोन के अंदर आते हैं वेयर एक्चुअली इट इज लेस देन 5 per 100,000, और ये भी ओवर पीरियड ऑफ टाइम इज गोइंग टू चेंज, दिस इज चेंजिंग, ठीक है। फॉर एग्जाम्पल इंडिया, ईरान was low zone, it was like less than 5, now Iran is very high zone, 15 to 25 per 100,000। और ये एवोल्यूशन ईरान में इसलिए आया है कि लास्ट 20 years Iranian government has giving free treatment for multiple sclerosis. So as the government decides to give free treatment, then the diagnosis increases and the treatment and the data improves. So that's what I think the difference is. Hopefully in Pakistan, it will change over a period of time. Abhi tak there is no population-based prevalence incidence data from Pakistan. This is like an old article about 20 years ago we published, and we compared MS in Pakistan related to other Asian countries. And we thought that Pakistan MS is largely cranial MS, less opticospinal MS, and more disability as compared to other parts of the world. So this is kind of, but we had this, most of the data in Pakistan is coming from hospitals. So that's why there's a selection bias, and more patients with disability come to Pakistan. Now, so far, literature related to MS in Pakistan is very limited. Maybe like altogether 20, 25 papers published from Pakistan. Most of them are single hospital based or some multi-center. Altogether, maybe 1,000 patients data. And they have used varying criteria, outcome assessment, no population-based data. And this is Harris did a analysis, meta-analysis of studies published from Pakistan. So there's a list of about 15 papers they were published from Pakistan with the number of patients and the criteria they use. So it's a very useful paper if you want to look at the MS literature from Pakistan. Now, this is first MS study we did in Pakistan that was like multi-center study. We collected 142 cases from 5 centers, and that was published in MS Journal, which is the premier journal for multiple sclerosis. And where this basically showed that our opticospinal is 3%, relapsing remitting is 81%, and 45% patients were moderately disabled, and 31% were severely disabled. So this is what the hospital-based MS is. A lot of patients. Now it's changing. So we are seeing a lot of patients who are young with very little disability and they are on disease modifying treatment. And two-thirds of the patients who we saw like 10 years ago, they became disabled in 5 years. Now, this is an incidental study we did a few years ago in collaboration with Karolinska. There's no study of incidental MS in Pakistan. So that was published in JNNP in 2010. And basically, we looked at the MRIs of patients done for some other reasons. And we found that 6 patients had multiple sclerosis lesions. So that's a big number. 6 patients out of 864, 7.7% had MS lesion. They were never diagnosed with MS, so they were incidental MS. And they have a good number of lesions. And some patients we followed, they went on to develop multiple sclerosis. Now, this is a study we did for related to genetics of MS in Pakistan. That was done by support of Biogen, and that was again published in MS Journal. And basically, we wanted to look at the HLA typing of patients with multiple sclerosis in Pakistan. So that was a 7 center study, multi-center, and it was started in 2009 and completed in 2010. And we looked at the prevalence of various HLA haplotypes among MS patients and compared to the population-based data, and we looked at their disability. So it was interesting data from different centers in Pakistan, and we enrolled 100 patients, the mean age of 32. 23% developed severe disability within 5 years of symptom onset. So that, and we looked at their HLA profiling, that how can this be predictable. So very high disability uh, in patients who, especially with primary and secondary progressive MS and spinal cord involvement. So these are the two important predictors of aggressive MS in our patient population: is spinal cord involvement and primary and secondary progressive type of multiple sclerosis. And when we compared the HLA type of MS patients versus control, so there was no statistically significant difference among as compared to population. But what we find out that patients who have a higher disability, that was statistically significant for presence of DQB10203 haplotype. So this haplotype is basically may be suggestive of a higher disability in patients who have multiple sclerosis. So if you want to predict that this patient will develop higher disability, this may be a predictive model for those patients. So there was no significant difference in HLA-DRB1 and DQB1 among patients as compared to populations. High disability I discussed, and then if you look at all the data related to MS in Pakistan, so it's variable. Again, female preponderance, mean age is about 29 years, probably because we don't have a lot of data related to pediatric MS. Now, if we have data related to pediatric MS, this age will come down quickly. And this is something which needs to be done in Pakistan. There's a lot of diagnostic delay. There are a lot of underdiagnosed cases. Still, we see high disability. All the literature related to MS you see in Pakistan, you will see higher disability. And because I think selection bias, because you are just looking at the tertiary care hospital, and we are still seeing patients with rapid progression of disability, that's again related to selection bias. Largely still relapsing remitting 70 to 90%. We have NMOSD optic spinal MS is 3 to 20%. There's some data related to optic neuritis and transverse myelitis in Pakistan published data. So there's no systematic study of MS treatment in Pakistan. There are suggestions that a lot of people use steroids, monthly steroid injections. But whatever data we have looked at, about less than 50% of MS patients, they are receiving disease-modifying agents. So about 50% still are not on any disease-modifying agent. And these are different kind of agents that have been used among different patients. So we looked at uh, the data of about 188 patients, and we found that these are the treatments given. We have some awareness of EDSS, but almost no study have looked at the EDSS of MS patients, so no systemic data. Very little mortality data related to MS. And whatever we know for sure that whatever MS we have so far, which is published, is much worse as compared to the Western data. This is a paper we published in International MS Journal, and we looked at the treatment pattern of multiple sclerosis among 88 patients. So you can see that almost all kinds of treatment have been applied in Pakistan, including like immunoglobulins and leflunomide and mitrozentron, monthly steroids, regular steroids. So all kinds of injections and treatments have been applied in patients. And this is, we are doing this Paktrims conference for now 5 years. So we have published some of the data presented at the Paktrims conferences in the previous years. Now, this is a study we did a few years ago that was published that we validated an Urdu translated version of EDSS, and we did it a telephone validation. And actually, it was very good that pretty much you can identify the EDSS based on a telephone interview from patients. So this is kind of uh, a way to identify the disability. You can do it in person too, and you can do a telephone interview of the patient and document that what's the EDSS of patient. This is something which we are struggling for a few years. Hopefully, it will take off this year in 2026. So we started National Multiple Sclerosis Registry, and so we have not been able to start a national registry yet. And this is a paper a few years ago, last year published. This is an abstract, not a paper. So this was someone looked at the GBD data and find out that patients in Pakistan, the prevalence and incidence is increasing of multiple sclerosis in Pakistan based on GBSS data. Now, this is a paper Harris published, which is the largest neuromyelitis optica paper from Pakistan. So this is a very good paper. If you want to look at this, is a very good data, and Arsalan also, his team is going to present data related to MS in Pakistan, especially immunology. This is the editorial we published last year. Last year, Ahmad Wali published the first data of ocrelizumab in Pakistan. So we now know that about 600 to 800 patients have received ocrelizumab in Pakistan, or maybe more. But this is the first data of 22 patients that was published by Ahmad Wali and his team last year. So we need to publish more of these data from Pakistan. And this is a paper Farooq Rathore published, which is a very good paper related to multidisciplinary rehabilitation strategies for multiple sclerosis patients, especially in relation to Pakistan. This is something all of the people who are treating MS patients, they should be working in collaboration with rehabilitation for improved outcome of those patients who have multiple sclerosis. This is the a signing off or National MS Registry. It's a collaboration between Pakistan Society of Neurology and Roche Pharmaceuticals. So hopefully this will take on, this will launch soon. It's in the regulatory approval process right now. So our future plans is to continue with Paktrims. We want to start the registry this year. We already have an NIH grant for population-based evaluation of neurological diseases. So hopefully that data will provide some information related to population-based prevalence of MS in Pakistan. We still have very few MS training workshops in Pakistan. We have a good number of neurologists now, but very few training workshops. Number two, we are not doing much cognitive assessment in MS patients. So this is something which is kind of recommended across globe, that all patients with multiple sclerosis, you should have some cognitive assessment, because MS has a huge impact of cognitive function. So this is something which we think that we should start on the platform of Pakistan Society of Neurology, at least maybe 2 or 3 training workshops and courses related to MS, and especially the new development. Another important area in Pakistan which it needs to be worked is patient support program. Now in Balochistan, the government is providing ocrelizumab free of cost. And I know some of the patients from Karachi, they are going to Balochistan to get the ocrelizumab treatment. The government of Sindh is not providing anything. Punjab, some places is covered by health cards. So I think some data will be presented today. And KPK, it's kind of a lot of hospitals, they are providing ocrelizumab free of cost based on health card. So there is some patient support program. There was a federal program which was supported by Baitul Mal, and that is covering some other hospital. But I think this is something we need to work on, because this is not only patient care, but if we want to improve the compliance, then this is something we have to do the advocacy so our patients can get the treatment, and we could rightly connect them to the people who can provide them the treatment. We need to organize monthly lectures, especially for our neurology trainees. Now we have about 400 neurology trainees in Pakistan in different years. So we need to have some dedicated MS training. But there's one thing I think which we have talked to Dr. Omapati, who does a lot of neuro-ophthalmology course, because there's a lot of involvement of optic or cranial nerves in the MS, especially the third, fourth, and sixth nerve. So maybe we want to organize a neuro-ophthalmology course. And this year we have recommended one of our trainees to MS PATKRIMS fellowship. So if she is elected, then that would be the first person from Pakistan who has a dedicated MS fellowship. And hopefully, if she is able to get the fellowship done and she comes back to Pakistan, then that will be a good contribution. So MS is not uncommon. Still a lot of awareness and research is required. A lot of doctors training. We have not trained general medical doctors, family physicians, or internal medicine doctors for multiple sclerosis. I think we need to target those doctors. We need to target ophthalmologists because they do see a lot of optic neuritis, and they never refer those patients to us for further treatment and evaluation. So this is something we have to train. And MS registry, I think we have to start and launch across Pakistan, and we have to collect a good data related to MS in Pakistan. That's going to be good. And we have to publish more papers. A lot of people, you will be looking at the data from 10 different centers in Pakistan. So we are doing like training, research, different kinds of the therapies, but we are not publishing that data. So maybe we should combine all that data and publish. So at least 1, 2, 3 papers related to MS treatment should be published from Pakistan. So again, I would request Haris to take the lead and get everyone together. We have the data, and people will be presenting. Maybe just combine the data and publish in local journal or international journal. That would be good. And one thing I think we have to work as an organization and is the patient support program. So we have to come up with some other ideas. There's a lot of money available at different places in the country. Like Baitul Mal has some other support programs, they have money. The governments, they have money. CSRs, they have money. So maybe we have to find a way to how can we connect our patients to those kind of philanthropies so they can get the right treatment. Because everyone with MS, even with mild to moderate MS, even with incidental MS, or even like with no symptom, they need to be on some kind of disease modifying treatment. And this is something we have to work on in future. So again, I would like to thank the organizers, especially Harris and Roche Pharma, for supporting this. And hopefully today's conference will be very informative. It would be a good learning experience, and hopefully it will not only promote information, but will improve patient care across Pakistan and improve patient care across Pakistan. And that will be a large help for Pakistan. We have a lot of online lectures from like Middle East, US, UK, and different parts of the world. So hopefully that would be a good learning experience for you. Thank you very much. Any questions? चलो, thank you.
थैंक यू कोई सवाल नहीं तो इतना अच्छा समराइजेशन किया है उसमें कोई तो मेरे ख्याल में जो है ना ये ओवर द लास्ट 20 years as you have presented what we've been publishing, अब डेटा थोड़ा आसान हो गया है क्योंकि ज़्यादातर लोगों को ऑक्यूवस ही लग रही है. द रीज़न बीइंग इज अवेलेबल इन बैतुल माल और हारिस के पास, इनके पास भी. अगर कोई नॉन अफोर्डिंग पेशेंट हमारे पास भी आ जाता है तो आई जस्ट हैव टू कॉल हारिस के वी आर ये नॉन अफोर्डिंग एंड वी यूटिलाइज द फंडिंग अवेलेबल. सो आई थिंक जिस तरह ईरान में आपने कहा है ना कि जैसे जैसे फंडिंग अवेलेबल होगी और हाई एफिकेसी ड्रग आपके पास है तो देन आई थिंक दैट्स द वे टू गो. वील हैव मोर डेटा. कम्युनिटी लेवल डेटा इसलिए नहीं है क्योंकि एक्सेस ही नहीं है उनके पास, डायग्नोज ही नहीं होते
लेकिन जो हम कर भी रहे हैं ना वो भी पब्लिश नहीं हो रहा है.
उसमें.
That's something we have to work on. मतलब what happens that if you publish more, then you have more awareness, and then people kind of start doing and testing and looking at it ना. तो मेरी दरख्वास्त तो सबसे ये है कि भाई जितना डेटा भी हमारे पास है पाकिस्तान से उसको हम अगर कंबाइन करके पब्लिश करें. और दूसरी बात है कि जो एरियाज अदर है ना जिसपे रिसर्च करने की जरूरत है, जैसे जो लोग फॉर एग्जांपल कॉग्निटिव टेस्टिंग कर रहे हैं ना एमएस के पेशेंट्स में, वो उसको कंबाइन करके पब्लिश करना करें. तो मल्टी सेंटर अगर हम काम करना शुरू करें तो दैट विल हैव अ ह्यूज डेटा फ्रॉम पाकिस्तान. और दूसरी बात है कि वो डेटा विल इम्प्रूव द केयर, डेटा विल इम्प्रूव द एक्सेसिबिलिटी, और तमाम चीजें दुनिया में जो है ना इसी तरह होती हैं.
अच्छा, दूसरी चीज जो हमने देखी है ओवर द लास्ट 20 years, इवन दोज केसेस के हु वर माइल्ड एट ऑनसेट और दोज हु रिफ्यूज्ड डिजीज मॉडिफाइंग एजेंट्स, वी हैव पेशेंट्स के पिछले 20 साल से हमसे हमारे पास आ रहे हैं, तो फिर वो आफ्टर अबाउट 10 years 15 years दे हैव वर्सनड एंड अल्टीमेटली दे हैव गॉन ऑन डिजीज मॉडिफाइंग ट्रीटमेंट. तो अगर अगर किसी चीज़ ने स्टार्ट किया है क्लिनिकली आइसोलेटेड सिंड्रोम या रेडियोलॉजिकल आइसोलेटेड सिंड्रोम की तरह और शुरू में रिफ्यूज़ किया डिजीज मॉडिफाइंग ट्रीटमेंट, 10 साल 12 साल 15 साल के बाद जाके वो फिर सेकेंडरी प्रोग्रेसिव हो जाते हैं और फिर वो रुकते नहीं.
अच्छा, अभी इस पे दुनिया में ना कोई वो नहीं है, मतलब कोई डिस्प्यूट नहीं है, कोई कॉन्फ्लिक्ट नहीं है. बट देयर इज कंसेंसस अक्रॉस द ग्लोब कि if someone has MS, even radiologically isolated syndrome, clinically isolated syndrome, relapsing remitting syndrome with like just one event, they should be on disease modifying treatment, because that's the only way you can get NIDA. Otherwise, if the patient has already 3 episodes, then you already lost a lot of neurological function ना. तो अभी there is pretty much consensus across the globe कि आप पेशेंट को आइडेंटिफाई करके और उसको एज सून एज पॉसिबल ट्रीटमेंट शुरू करें. जो हमारे यहाँ एक प्रॉब्लम है कि पेशेंट आइडेंटिफाई लेट होते हैं, और दूसरी बात है कि दे डोंट गेट द राइट ट्रीटमेंट, और उसकी एक बड़ी वजह अफोर्डेबिलिटी है. तो अगर किसी तरह हम गवर्नमेंट्स को ही तैयार कर लें कि अगर पाकिस्तान में मिसाल के तौर पे हम हर साल 1,000-2,000 लोगों को गवर्नमेंट ही फ्री एमएस की ट्रीटमेंट सप्लाई करने लगे, तो उससे आप काफी हद तक लोगों को तो प्रिवेंट कर सकते हैं ना आगे बीमारी के बढ़ने से. ठीक है, थैंक यू.
Thank you, Professor Wasay, for such a detailed review. And the efforts of Professor Wasay and Dr. Haris are truly commendable for bringing and bridging therapies for MS in Pakistan. So moving on to our next speaker, we have Dr. Burhan Chaudhry, who has joined us live from USA. Dr. Burhan Chaudhry graduated from Shifa in 2005 and did his residency in Mississippi. He's a neurologist specializing in neuroimmunology and multiple sclerosis, and he's also the lead for CAR T cell therapy in multiple sclerosis. And he will talk on cell therapy in autoimmune neurological diseases, a topic so futuristic, I'm sure our neurons will grow more dendrites listening to it. Over to you, Dr. Burhan.
Thank you. Assalamu alaikum. First of all, thank you to the PATKRIMS organizers for inviting me. It is always a pleasure. You guys do a fantastic job. And thank you for everything you are doing for, MS patients and these CNS autoimmune patients, for them in Pakistan. So thank you. Second of all, apologize my appearance. I just got off a very long ICU shift. I did not want to be late for this, so, apologies. Professor Wasay is a tough act to follow, but I will try my best. And it was very insightful to hear, the current status of MS in Pakistan. And it's true that, MS seems to be more prevalent in Pakistan than definitely, we would have imagined. And Professor, मैंने एक चीज़ यहाँ भी नोट किया है. I practice in the US, तो यहाँ पे जो पाकिस्तानी experts हैं, उनमें भी काफी, you see, a lot of them with MS. And then I get referred patients from the UAE, from Africa, from South America as well, जो Pakistani experts हैं. So it is interesting that the rate of MS within our population is definitely higher than what is reported, as you were alluding to. But moving on, and also it was very heartening to hear that almost 1,000 patients of Pakistan are on B-cell depleting therapy, which has now become the standard of care in MS, and rightly so. They do a fantastic job, especially for the inflammatory phase of the disease, progressive phase of the disease, even though it is approved for primary progressive MS. Unfortunately, the real-world data is not all that great, and there are reasons. But even though it is the standard of care, they do a fantastic job. We can do more, right? And that's where cell therapy comes in. This is a modality that in the last 3 years has taken on a lot of excitement. And rightly so. I will go over some of the technical aspects of what these are, how they came about to be tested in autoimmune diseases, what we have seen so far in these autoimmune neurological diseases, and hopefully the future looks promising. So without further ado, as we are all aware that these CAR T cells, which is a part of cell therapy, these are chimeric antigen receptor T cells. So these are T cells that are engineered, that are manufactured to become CAR T cells, and they are directed at B cells. And the technical aspect of this is so specific that you can target them for specific receptors on B cells. So as we are all aware that the currently approved B cell depleters like obrolizumab, that acts on CD20. So these CAR T cells, they can also act on CD20s. They can be manufactured to act on CD19. They can also be dual acting. They can act on earlier line B cells, which are BCMA cells. So the science behind this is really fascinating, and it's very specific. And they first got approved for hematological B cell malignancies. That's where they made a very serious dent in patients who had a high unmet medical need, who were treated, who were diagnosed with these refractory leukemias, lymphomas. CAR Ts were introduced in that area, and they have really revolutionized how those patients are treated. So since these CAR Ts are acting against B cells, now hindsight is 2020. Now you think that obviously it makes a lot of sense that we should try these in autoimmune diseases that are driven by B cells. But that thought didn't really come along until a rheumatologist in Germany who published this paper. This was a case series of 5 patients. His name is Jörg Schett. He was the leading author on this paper. He took a refractory lupus patient. Now we know that lupus is predominantly B cell driven. B cells play a prominent role in the pathophase of that disease, and they use a lot of B cell depleting therapy in lupus. So he took a refractory lupus patient. He took a CAR T cell which was targeted towards the CD19. So it was a CD19 CAR T cell that he gave to this patient. At that time when this was happening, a lot of people thought he was crazy, because as we will discuss, these CAR T cells, they do come with significant side effect profile. But he gave this patient who was extremely refractory. This paper was published back in 2022. So the first patient he treated, then he treated 4 more patients, and he published this case series. She has been treatment-free, off medications now for 3 years. And this was someone who had very, very bad disease. So it was really this case series that got everyone's attention that, we need to look at other diseases where B cells play a prominent role. Obviously, there are quite a few autoimmune neurological diseases where B cell therapy play an important part. multiple sclerosis being one of them. So that's why then after this, a lot of interest was garnered. So before we go into the clinical data, I just want to go over a little bit about, what these CAR T cells actually are. So as we are aware that, that our regular T cells, the activation and killing, it requires this complex integration of cues, and antigen presenting cells play a prominent role. So the antigen presenting cells are really going to recognize the antigen as abnormal, and then that will start the co-stimulation response. And then what happens is that when these CAR T cells are manufactured, they combine all of the required recognition and signaling into a single molecule, which then elicits this antigen cell targeting and killing. And this is why they are so precise. Now, one serious advantage that CAR T cells have over the traditional B cell depleting therapies, that they cross into the blood-brain barrier. Now, from the hematological world, there is very clear data that these CAR T cells are present in the CSF. So what they did is that on a number of patients with non-Hodgkin's lymphoma, they took their CSF samples. And a CSF sample with a patient who has CAR T cells, it looks a lot like lymphocytic pleocytosis. So the white cells go up, which are predominantly lymph, and that's a dirty way of telling that these CAR T cells are in the CSF. But then PET scan studies have also been done, which have clearly shown that these CAR T cells. I'm sorry, was there a question?
मैं उसको म्यूट कर दें, बाकी लोगों को म्यूट कर दें, कोई और किसी का माइक ऑन है बीच में.
जी. So there is very clear data that these CAR T cells get into the brain. So they cross into the blood-brain barrier, into the CNS in a high concentration, which unfortunately our traditional B cell depleters cannot do. They do get into the blood, they do get into the CNS through the blood-brain barrier, but it is at a very, very low dose where they don't really have much impact. But CAR T cells, which are millions of cells, they all get into the CNS. Now, why is that exciting for autoimmune neurological diseases? Because as mentioned that, a lot of these diseases are B cell driven, not only in the periphery, but in the CNS as well. So these CNS resident B cells, we really have not had the right ammo really for these cells to be, really gone after. So now with this modality, we do have something that will get into the CNS in high concentrations, and then hopefully can clear out the CNS resident B cells, these pathogenic B cells. Now, with that in mind, and with the data set that came out of Germany, obviously then a lot of activity started around clinical development, where quite a few companies and then quite a few CAR Ts, were brought into the space. And so this is one of the construct over here, where you can really have this, like I said, you have the CAR T cell, which is intracellular. It has a transmembrane domain, which attaches itself to the tumor antigen, and then lyses that tumor cell. All right. So now with that in mind, that CAR T cells, they can deplete these B cells. And like I mentioned, they get into the CNS in high concentration. They also get into other tissues as well in very high concentration. So they have deep tissue penetration, especially in lymph nodes. And that's where these lymphocytes are coming from. So we have a lot of data now across both the hematological literature and our early autoimmune literature as well, is that these CAR cells, they induce a deep B cell depletion. So on your left, you will see that the level of deep B cell depletion that is being achieved by CAR T cells as opposed to the superficial B cell depletion, which is really done with the current B cell depleters. And this depletion happens very quick. I will show you data where B cell depletion occurs within days. And then it takes about 3 months for these B cells to come back. And the important thing is that when these B cells come back, they are naive B cells. They are not pathogenic B cells. So that's what's really differentiates this B cell depletion from the rest. And that is why it is, referred to as a quote unquote immune reset. Now, how durable this immune reset is, how many years, that only data will tell, and the more follow-up we have. So this is this was a recent poster published at PATKRIMS, where a handful of MS patients, both relapsing and progressive MS patients, were treated with a CD19 directed CAR T. Now you can see towards the right of the slide over here is that these patients over here, if you can see my cursor, these are the B cell levels at baseline before they got CAR T. Now you will see that most of these patients have low levels of B cells at baseline. It's because a lot of these patients had been exposed to B cell depleting therapies. Now, once CAR T was given right here, you see that the B cells are completely gone. So B cell depletion happens very quick. And then you start seeing them come around day 57. So around 2 months and then around 3 months. So 2 to 3 months is the time frame when you see them come back. And if you see at these two plots over here, you will see that the majority of cells that are coming back are naive B cells. And that memory B cells you will see over here and over here as well, is that they have a decrease. So these B cells that are coming back are not pathogenic. So again, alluding to the same concept that these are quote unquote, there's a quote unquote immune reset. To the left over here is a graph that is essentially a representation of the CAR T cells. So these CAR T cells, they expansion, though this is basically expansion within the patient. They expand within millions. And all of these million cells, they get deep into multiple different tissues, including the CNS. So again, robust expansion, deep, early, complete B cell depletion, followed by repletion of B cells around 2 to 3 months. And then majority of them are naive B cells, and memory B cells are gone. Now, you are all aware that with the current B cell therapies, peripheral B cell depletion occurs, and it takes them on average about 6 months to come back. And not a majority of them are naive. So there are these subtle differences. Now, this whole process for patients is not easy. It is cumbersome. It is a process where the science is fascinating. The outcomes have the potential to be incredible, but it is a process for patients. You know, as I was saying that these autologous CAR T cells, they are manufactured. So what happens is that once a patient is recognized and, you know, they agree to this, they undergo leukapheresis, where basically they are coming into centers, giving their blood. And then from that blood, leukapheresis occurs, and T cells are taken from that sample and they are manufactured into CAR T cells. This manufacturing process varies. You know, there are based on different products, based on different targets. The manufacturing time can be from anywhere to two to 6 weeks. So once they are manufactured, they are available. Before these CAR T cells are given, you will see that lymphodepletion the therapy over here. So this lymphodepletion chemotherapy is achieved with a combination of cyclophosphamide and fludarabine. Now, both of these agents are used in autoimmune neurological diseases, but the doses you see over here are much less. Nonetheless, they both are given. Why are they given? The aim is over here to achieve immunoablation, so that when these CAR T cells are given to the patient, they have room to expand. You saw the graph where I showed where they have, you know, rapid expansion, and that expansion leads to the immune reset, where you have depletion of B cells happening very, very quick. So it does require the lymphodepletion chemotherapy with fludarabine and cyclophosphamide, which we all know do have you know, associated side effect profile, especially for younger females. So once the LDC is done, that's when the CAR T cells are given. And for a lot of these early trials in autoimmune diseases, since we don't really know how it's going to affect patients from a safety standpoint, we require the patients to stay in the hospital anywhere from 1 week to 2 weeks. So this whole process for the patient can take months. So it is time consuming. It is not easy, and it does have a lot of steps. So that is something that I wanted to call out. Now, with that in mind, you know, like having talking about, you know, CAR T, and we talked about the first lupus patient that generated a lot of excitement. We have now had multiple autoimmune neurological diseases where we have seen either case reports, case series, or there are large clinical trials being run. So over here, you will see CIDP, stiff person syndrome. The data in stiff person syndrome is absolutely phenomenal. And I am pretty sure that it will get approved for stiff person syndrome very soon. Unfortunately, we don't have time. I can't go into all of these cases, but if you have a chance, please do a literature search on CAR T and stiff person syndrome. Those case reports are very impressive. The same goes for myasthenia gravis. Over here, the case reports and series we have seen are very, very impressive, and that would make sense because myasthenia gravis is like the prototype for B-cell driven neurological autoimmune disease. And again, I would highly recommend that you do a little literature search on this. The outcomes have been fantastic. Where there was one patient who, because of her myasthenia, was trached. She, because of myasthenia exacerbation, she had 3 ICU admissions within 2 months. She was treated with an CD19 directed CAR T. She is off all therapy. She is mobile, she is active, and she is living life. So again, the results have been very impressive. Multiple sclerosis. Yeah, you know, there are multiple trials, large trials. As mentioned, I am part of one trial as well, where we are treating both relapsing patients and progressive patients. And since these patients, B-cell therapies have played a prominent role, it does make sense that, this be tested over there as well. NMOSD, again, is an autoantibody-driven CNS disease, where we saw this early trial run out of China, and the outcomes were impressive. There was recently a case report published in MOGAD, and this was published out of Spain. Lambert-Eaton syndrome, along with myasthenia. Recently, a case of autoimmune encephalitis, treatment refractory autoimmune encephalitis, where they got the CD19-directed CAR-T with a very impressive outcome in a patient who just had a very, very poor clinical outcome. So a lot of excitement, and rightly so. I've shared some of the literature as well. This was all of the early literature that so far has been published. This is the trial that was done in NMO. This was done in China. This case series of patients with concomitant myasthenia and Lambert-Eaton, this was published out of Germany. Stiff person syndrome. Then this was the first two cases of multiple sclerosis, and then the autoimmune encephalitis patient as well. I will say that really Germany has been the one that has really taken the lead on this with their early work, where a lot of these case series and case reports were published. So a lot of early work has been done there, and all of us are now following suit. So I did also compile, all of the cases that have been published so far. So we do have published 38 cases across autoimmune neurological diseases where we do have data. Much more patients have been treated with across these multiple diseases, but that data has not been published yet. So you will see that you have the most number of patients, MS patients, quite a few with myasthenia, and then NMO, and then these case reports in SPMS, MOGAD, autoimmune encephalitis, and CIDP. The early data for MS has looked promising, where these patients, there has been stabilization of their disease. The early data in myasthenia so far has looked very impressive. Patients have responded very early to it with drastic improvements in their disease state. The NMO literature that was published out of China, that was also very promising. There was one patient out of 12 who did have a mild optic neuritis after they got CAR-T. But all of the other patients did have improvement in their EDSS scores. So far, early days, we are still running phase 1 trials, but the data has looked very promising. The safety has also looked very good so far, different from the patient profile in hematological diseases, but still, it is early days, and we will go over some of the safety issues associated with CAR-T as well. Now, I did discuss a lot of this, so I will move on to the next slide. This is just really saying, what the differences are between the traditional B-cell depleters and CAR-T. Now, I did want to focus on MS just a little bit, and so this is really, I have really summarized the patient profile that is being recruited into clinical trials for CAR-Ts. And since this is an early phase trial, safety is the primary endpoint. It is, what we really are honing on, but with the safety, we're getting a lot of efficacy data as well. And over here, you will see is that we are really taking in patients with moderate to severe disease. So the baseline EDSS has to be 3 or higher. If it is 2, 2.5, where majority of our MS patients are, they are not recruited. And these progressive patients, they must have proof of progression on ocrelizumab, which is the only approved therapy for primary progressive MS. And non-relapsing SPMS or inactive SPMS, the same story. These patients must have moderate to severe disease. When it comes to relapsing MS, similar story. We are recruiting only moderate to severe patients. You will see that the upper age cutoff for these patients is a little low. Again, just because, we wanted to make sure it is safe to give to these patients. And then again, these patients must have disease activity on the high efficacy DMTs. So patients who have had breakthrough disease on any of the B-cell depleters, alemtuzumab, natalizumab, cladribine, all of these high efficacy DMTs, only those patients are being recruited into these studies. So really patients who are truly highly active. Now, I did want to quickly just mention myasthenia as well, because there's a lot of excitement in myasthenia, because we have these B-cell activated acetylcholine receptor autoantibodies and MuSK auto antibodies, which are B-cell driven. So it makes a lot of sense that the CAR T cells should have an impact on this disease as well, since CAR Ts do directly target B cells. And these are the kind of patients that are being recruited into the clinical trials. These refractory patients, again, who don't have a mild disease, the MGFA classification has to be at least 2B for them to come into the study. The ADL score is 6 for these patients, and that is really to make sure that we are able to recruit some patients. But some of the case series, if you look at, some of these patients have, drastic improvement in their MG-ADL score after they get CAR Ts. And these patients must have had, a disease breakthrough or relapses on the approved myasthenia therapies. As I mentioned, that CAR T for patients, it is a long process. It is not easy. It is pretty cumbersome. And it then also comes with its own set of side effects as well. And since these CAR T cells, once they are given into patients, they are responsible for cytokine storming. There is an entity that can occur in patients that is known as a cytokine release syndrome. And that I will go over what exactly it looks like. Then CAR T cells, even though we are treating these autoimmune neurological diseases, CAR T cells are known to be neurotoxic. Just because they're getting into the CNS in large concentrations, there's cytokine storming. So there is a neurotoxicity that has been seen. And then T cell malignancies, since these are CAR T cells that we are giving to patients, T cell malignancies have been reported. The neurotoxicity in these patients is referred to as ICANS, which is immune effector cell-associated neurotoxicity syndrome. And this is basically really affects the patient's mentation, the mental stasis. The patients can also have seizures and motor weakness as well. And then cerebral edema has been reported as well. Excuse me. Now, I do want to mention that the rate of ICANS in autoimmune diseases so far has been much less compared to the hematological data. And the reason we think for that is that in the hematological data, it's very clear that the B-cell tumor burden directly correlates with the rate of ICANS. So if a patient has a large tumor burden that is just packed with B cells, the risk of ICANS is going to be higher. Now, in our autoimmune diseases, they do not have B-cell tumors. So the number of B cells in these patients is far less. And so maybe that's why we're not really seeing the neurotoxicity at the same rates. We are seeing it, but at a lower rate. And just this last quick slide, I'm sorry, I know I took up a lot of time, but but this is something that is in early days. It's very exciting. The future does look bright, where we may have, these CAR T cells have a major impact in these very tough to treat chronic diseases. And I've only talked about autologous CAR T cells where they have to be manufactured. So patients have to wait for it. There are also allogenic CAR T cells where we are taking T cells from healthy donors, and they are being manufactured and are available off the shelf. So patients don't have to wait. Recently, there are also another platform where we have in vivo CAR Ts. So in vivo CAR Ts would be is that we are basically injecting cells into the patient, and patients are going to generate CAR T cells within their own bodies by themselves. So you don't have to do any waiting around whatsoever. So really, the space has really taken off. The technical aspect of it is very, very exciting. It is very precise, not only in neurological diseases, but in autoimmune rheumatological diseases. It has made a significant impact in these early clinical trials, also within the autoimmune anemia space. There are early clinical trials running with very, very promising results. So hopefully, as time goes on, as we treat more patients, we will see where this space goes. But these are exciting times for sure. And with that, I do want to thank you all again for your time and for your patience. And I'm sorry if I went over time.
Thank you very much, Dr. Burhan. Dr. Wasay has a question.
Ji.
Burhan, is this treatment FDA approved or not yet? That's number one. Number two, is it a one-time treatment or recurrent treatment? And number three, what's the cost?
Professor Wasim, very, very good questions. It is not FDA approved yet. So these are all early phase clinical trials that are going on. And when I say not FDA approved, it's not FDA approved for these autoimmune indications. It is approved for the B-cell malignancies. It has been approved for quite a number of years. Now, for these autoimmune indications, we are close. Most likely, stiff person syndrome is going to be the first indication where it will get approval probably next year. Now, to the point of a one-time treatment, yes. The belief is that since this quote-unquote immune reset is happening and we are seeing these naive B cells coming back and the memory B cells are pretty much gone, is that this should be a one-time treatment with long durability. How long? That is a very good question. The hope is it will be one and done, but the longest follow-up we have is that one lupus patient who is now coming up at 4 years. And like I mentioned, for 4 years, she has been disease-free. She is off all kinds of treatments. She's not even on steroids. So we'll just have to wait and see, how long it is. But definitely, the hope is that it will be a one-time treatment. So that's where the excitement is. And that's why patients may be willing to go through all of the hassles for it. In terms of cost, the CAR T cells that are approved for the B-cell hematological malignancies, they're expensive. They run, for the CAR Ts that are approved, they run from anywhere to $500,000 US to 600 to 625 US dollars. So it is expensive. It is one time, but it is expensive. The hope is that with these CAR Ts, even though it will be a very high cost upfront, since it will be one time, it will not require multiple treatments, where these other immunomodulators, even though they're even dosed once a year or twice a year, you get treated for 5 years, 10 years, those costs do add up. But yeah, it is a very high cost upfront.
Okay, Burhan, one short question. How is CAR T therapy different from the resetting therapy, which is autologous, in terms of both ease of administration and in terms of cost?
So, Professor Arslan, if I understood your question, what is the difference between the autologous CAR Ts and the currently approved therapies?
Autologous stem cell therapy. That
Oh,
is
stem cell therapy. All right. Okay. No, absolutely. Yeah. So, that's also a very good question. Now, autologous stem cell therapy, as you are all aware, it works really well, you know. So, but that immunoablation is done at a much higher dose. You know, the dose that is used with CAR Ts for at least fludarabine and cyclophosphamide is much lower. So the doses used for the immunoablation over there are much higher. Because of those much higher doses, the side effect profile for stem cell is pretty bad, and they are long term. So, so that is one drawback. Another drawback when it comes to autoimmune neurological diseases is that stem cells really don't penetrate into the CNS. That's why you don't have that effect on progression. So for relapsing MS, it's a very good option. We all know that. For progressive MS, it is not, just because it doesn't have the ability to get into the CNS. Now, ease of, so both are pretty cumbersome for patients. But with the CAR Ts, usually these patients are hospitalized for the first 1 to 2 weeks. And these are early clinical trials. So hopefully, as these trials mature and we have more data, that hospitalization will be cut in half. With stem cell transplant, you are aware, since of these high doses, the risk of infections is so high. Risk of reactivations is so high. They need to spend some time in the hospital, and then after that, they also have to be very careful. So there are already quite a few differences when it comes to it. Now, we have been using stem cells for quite some time now, so we have a lot more data. With CAR Ts, we just don't have that same amount of data yet. But the initial data does look really promising.
Okay. Professor Tahira Aziz, one last question, and then.
Thank you very much. What a pleasure listening to talks about CAR T. Now, CAR T therapy is likely to be very effective once you have a careful selection of the patients where B cell derived products, that is antibodies, are demonstrated to be the main culprit for pathogenesis. So the question one is, the CAR T is unique T cell, chimeric. It has the defined antigen receptor, which is mouse origin, and then you have humanized co-stimulatory molecule into the same place where one T cell receptor was. So the one cell, once it combines, it stimulates itself as well and destroys the target. So that's the unique thing. So that makes it very expensive to produce. Do we have facilities where it can be produced, say, in sort of mini sort of machines which are available to the clinical laboratories, or still these cells are being produced in very, very specialized facilities? So that is one. The other thing I was thinking, that we are always talking about these very special population of patients where this is refractory to the standard treatment. And then you go on to try one of these things. CAR T is one, destroying B cells, destroying more B cells by CAR T. And what about the antibodies which are already circulating? And then the use of anti-complement therapy. So combining all of these three is likely to provide immediate benefit, removing antibodies, blocking complement, and then CAR T, use of CAR T for the long-term effects. So one, production, and then combining of therapies. Thank you.
Professor, very good question. I mean, that's you raised some very good points. To your first question, for the autologous CAR Ts, for most of them, the manufacturing is still being done at these highly specialized centers. So I will give you an example. The clinical trial that I am leading, we have one site in the US and one site in Europe. And so they are manufactured over there. It takes about 6 weeks. So once the patient gets AFed, the CAR Ts take about 6 weeks to be manufactured, which is a long time. Now, they are working on these manufacturing platforms to make them faster. But still, to your point, autologous CAR Ts, they are being manufactured at these, highly specific, highly specialized sites. Now, when it comes to allogeneic CAR Ts, the hope over there is that these allo CAR Ts can be manufactured on a large sample size, where we take healthy samples, we manufacture these CAR Ts, and basically they will be available off the shelf. So even though they are only being produced only at a few sites, but since they are being produced in large numbers, they will be available for your patients off the shelf. And that is already happening in the hematology space. Our hope is that as we know more and more about the space, as the technology gets better, the manufacturing platforms get better, the use for these highly specialized sites will be much less, especially with these in vivo CAR Ts, where these CAR Ts are basically will be generated within patients. So to your point, that is a concern now, but hopefully over time and with more work, that issue will be addressed. Now, you brought up a very good point of combining cell therapy with complements or checkpoint inhibitors. Combination therapy would be very exciting. The problem is that the regulatory bodies are not very open to it right now because of safety. They feel like combining these therapies is not a good idea yet, because we don't have a lot of data with these individual therapies in this disease population. So you raise a very good point. Hopefully we will get to that place. So once we have robust data over here, then we can go towards combination therapy.
Thank you, Dr. Burhan, for such an elaborative talk and taking out your precious time. And what time is there in US?
It's 12:30.
Okay, thank you very much. Have a good sleep.
Thank you.
Thank you. Okay, so now moving on to our next presenter, it gives us an immense pleasure to introduce Professor Fujihara. Professor Fujihara is the professor of Department of Multiple Sclerosis and Therapeutics, Fukushima School of Medicine. He's director, Multiple Sclerosis and Neuromyelitis Optica Research Center in Koriyama, Japan. He has major contributions to all the diagnostic criteria of NMO, MOGAD, and MS with major research publications. He's also the leadership of Japanese Society of Neuroimmunology. He will talk on the treatment of MOGAD.
Well, thank you very much for the kind introduction. Can you hear me?
Yes, we can
Yes,
hear
we
you.
can hear you, Professor.
Okay.
Can you please share your presentation?
Yes. Can you see my slides?
Yes, we can, sir.
Well, thank you very much. And I would like to thank Dr. Harris and the other organizers for this kind invitation. I'm joining you from Japan, and right now, 2 p.m. here in Japan. Not very late. So in this presentation, I'd like to talk about the treatment of MOG antibody-associated disease. As you all know, MOGAD is a relatively recognized clinical entity, but the research progress has been significant in recent years. So I'd like to share with you some data that we have at this point in terms of the treatment. So these are my disclosures. And let me start with the epidemiology. As you see here, unlike MS and NMOSD, there's no marked sex or racial preponderance. And the onset is on average 30 years old, but you can see patients from children to adults. And as for prevalence, it's much lower than that of MS. But important point is that up to 40% of the cases may be post-infectious. A variety of different infections may be associated with the onset of MOGAD. Post-vaccinal cases are much smaller in number, but a recent Japanese nationwide survey shows that top 2 vaccinations associated with MOGAD were number 1, influenza vaccination, and number 2, Japanese encephalitis vaccination. And unlike AQP4 antibody positive NMOSD, coexisting autoimmune disorders are much less in MOGAD. But one study published by Mayo Clinic showed that about 7% of the MOGAD patients may also be positive for NMDA receptor antibody. So it could be NMDA receptor antibody positive. And even if your patient has MOGAD, some episode may have to be attributable to NMDA receptor antibody rather than MOG IgG. And as for recovery, as you all know, the recovery is often very good, and the complete recovery is not rare. However, in some patients, the recovery is very poor. Some patients may have only the monophasic disease, but others may relapse, ranging from 30% or something to more than 60%, depending on the duration of follow-up. And unlike MS, essentially there's no progression in MOGAD. And unlike MS, there's no obvious latitude gradient, racial preponderance, or no strong HLA associations in MOGAD. I do not go into the detail of clinical pictures of MOGAD, but as you see here, in children, ADEM is the commonest clinical phenotype, followed by optic neuritis. But in adults, optic neuritis is by far the commonest clinical phenotype, followed by transverse myelitis. So depending on the patient age, you may see a different type of clinical phenotypes of this disease. Kevin O'Connor's group at Yale University recently reported the in vitro study on the pathogenicity of MOG IgG. And I do not go into the detail, but they used the in vitro system to analyze the pathogenicity of the autoantibody, and they clearly demonstrated that MOG IgG is pathogenic in terms of complement-dependent cytotoxicity and antibody-dependent cellular phagocytosis and antibody-dependent cellular cytotoxicity. They also analyzed a single case of autopsied MOGAD cases experienced at Mayo Clinic, So as you see here, there are active demyelinating lesions in the case, complement deposition, and CD68 positive macrophage microglia infiltration. They also analyzed the antibodies recovered from the patient, and they are definitely binding to MOG. And as for effector functions, they show that those patients, MOG-IgG, increase the membrane attack complex MAC formation, and the more MOG positive cells are killed by these autoantibodies. And as for antibody-dependent cellular phagocytosis, so patients MOG-IgG induced phagocytosis, and less MOG positive cells survived as a result of this pathomechanism. So they show that MOG-IgG recovered from the patients are pathogenic. Recently, a European group reported CSF granulocyte activation marker, GAM, is elevated in the acute phase of MOGAD. That granulocyte activation markers included neutrophil elastase, myeloperoxidase, and neutrophil gelatinase associated ligand, and MMP8. And as you see here, they are very high in the acute phase of the disease. And probably you have experienced patients whose CSF included a large number of neutrophils over lymphocytes. So the neutrophils should be treatment targets in the acute phase of the disease. MOGAD is essentially a demyelinating disease. And this patient, 31-year-old male, developed right optic neuritis first, and it showed good recovery. And 2 weeks later, acute myelitis, which is longitudinally extensive, but as a result of the high-dose corticosteroid therapy, it showed recovery, good recovery again. But this patient this patient fulfilled the criteria, diagnostic criteria of neuromyelitis optica, NMO. However, this patient was AQP4 IgG negative, but MOG-IgG positive. As for the cell damage markers in the CSF myelin basic protein was extremely high, but GFAP was less than the detection limit. So although this patient had NMO, MOG NMO is not astrocytopathic disease, but demyelinating disease. We expanded the study in the international collaborative study, as you see here. And again, in MOGAD, regardless of the clinical phenotype, CSF GFAP, so astrocyte damage marker, was not elevated in comparison with AQP4 positive NMOSD. But as for myelin basic protein, which is myelin damage marker, it was high. And in this analysis, it was higher than that of MS. And also, we should recognize that MOGAD is not purely demyelinating, but neuroaxonal damage can occur in MOGAD as well. So tau and neurofilament light chains were elevated in these studies. So in some patients, neuroaxonal damage may also occur. Now, let me talk about the acute attack treatment in MOGAD. A while ago, international survey was done, and everybody said that the first-line treatment for the acute attack of MOGAD was IV methylprednisolone, both in adult and children. And if they were asked, which treatment do you choose if you treat more for the acute attack? Then the top three were the plasma exchange and repeat high-dose corticosteroid and IVIG. And there are some studies that show the efficacy of IVIG in acute attacks of MOGAD. And also, IV methylprednisolone should be done earlier than later. This French study showed that if you start IV methylprednisolone less than 10 days of onset of attack, in comparison with 10 days or later of onset attack, best corrected visual acuity was better, as you see here. So the earlier treatment is important. That is also the case for acute plasma exchange for MOGAD. I do not go into the detail, but EDSS and visual acuity scores are better after the plasma exchange treatment. And also on the right-hand side, you see predicted probability of complete recovery and clinical significant improvement. In both parameters, if the patients are older, the recovery is poorer. And if you start plasma exchange later, the outcome was poorer. So essentially, the plasma exchange was effective to improve the outcome in MOGAD attacks, but the poorer recovery was associated advanced age and delayed initiation of plasma exchange. Although in this study, there was no control group, so further studies are needed to confirm the results. But at any rate, early start of the acute phase treatment is definitely important for the better outcome. Again, generally speaking, the recovery of the MOGAD attacks are usually good. However, not always. The red column shows only moderate or poor recovery after the acute treatment, and it ranged from about 10% to more than 40%. For example, in this clinical phenotype analysis, LETM showed the highest frequency of moderate or poor outcomes. And on the right-hand side, age, again, seems to be a factor associated with poorer outcomes. So not all MOGAD attacks recover quite well. That's quite important. And also, some acute attacks could be very severe and could be life-threatening. This is one case of the two case reports published by the Professor Brenda Baumwert's group from the University of Pennsylvania. And the patient, this 7-year-old boy, developed a very severe encephalopathy. And here you can see that the multiple cerebral cortical and subcortical white matter lesions and the severe brain edema. And the patient was MOG positive. But then they decided to, by the way, the patient was unfortunately unresponsive to IV methylprednisolone, IVIG, and plasma exchange. But then they decided to treat the patient with the IL-6 receptor because the IL-6 level in the acute phase cerebrospinal fluid in MOGAD is quite high. That's based on our study. And following the tocilizumab, an IL-6 receptor blocker treatment, the patient started to show recovery. So this is our study on the Th17-related cytokine elevation in acute phase of CSF in MOGAD, AQP4 positive NMOSD, and MS and control. And as you see here, IL-6 and other Th17-related cytokines are very high in MOGAD and AQP4 positive NMOSD in comparison with MS and control. On the right-hand side, this figure shows the significant correlations of the CSF cytokine pairs. That the black boxes show the significant the correlated cytokine pairs. For example, if IL-6 and IL-8 are significantly correlated, that box becomes black. And as you see here, in MOGAD and AQP4 positive NMOSD, multiple cytokines shows the significant correlations. But surprisingly, in this analysis, no cytokine pairs in MS were significantly correlated. So based on these data, so I can tell you that coordinated upregulation of multiple cytokines, in particular Th17 related cytokines, including IL-6, occur in these two autoantibody associated CNS inflammatory disorders. Well, you may think that just like the high efficacy of complement inhibitor eculizumab, ravulizumab in AQP4 IgG positive NMOSD, so those complement inhibition may be effective in MOGAD. However, we previously reported that in comparison with AQP4 positive NMOSD, you can see that dense deposition of activated complements, perivascular deposition of activated complements in MOGAD were much lighter, much milder, almost none. But on the other hand, European group reported a very different results. They observed complement deposition in all cases. So what makes this difference? Different cohort, or different method, and so on. But as I said, MOG-IgG induces complement phagocytosis and the cellular cytotoxicity in vitro. So anyway, MOG-IgG is pathogenic. And MOG-IgG is just like AQP4-IgG, essentially IgG1. So it should activate complements efficiently. However, so as I said, two histopathological analyses of MOGAD were very different in terms of the complement deposition. And my colleague, Yoshiki Takai, went to Roman Hoftberger's lab in Vienna and analyzed their cases and our Japanese cases by the same method. And he found that there are two patterns of complement deposition, weak deposition and strong deposition. And for example, in biopsied cases, type A, weak depositions are more frequent, but in autopsied cases, strong deposition were more frequent. And for some reason, AQP4-IgG, also IgG1, shows stronger complement activation than MOG-IgG in vitro. That was a report by the Austrian group. And more recently, we analyzed the complement components in the acute phase of MOGAD in the CSF. And C5a was equally elevated in MOGAD and AQP4. However, C5b9, which is membrane attack complex, was much higher in AQP4 positive NMOSD than MOGAD. However, if the MOGAD patients were classified into two groups based on the severity, EDSS score less than 3 or the EDSS score 3.5 or greater, in severe cases, C5b9 were higher. So if the disease is severe, complement inhibition may be effective in the acute phase of those patients. Now, let me move to relapse prevention in MOGAD. We previously reported the 10-year follow-up MOGAD cases, and in this analysis, we showed that relapses were seen in about half of the MOGAD cases. This is a comparison of MOGAD and AQP4 positive NMOSD. So NMOSD patients experience relapse in the majority of the cases. However, the relapse ratio frequency was lower in MOGAD, but in this 10-year analysis, many of the relapses were seen in the first 5 years than in the second 5 years. But the number of relapses vary from only 1 to more than 20 or 30. So it is heterogeneous in terms of the number of relapses in MOGAD patients. Then what about the efficacy of immunosuppressing agents to reduce a risk of relapse in MOGAD? These studies show that in comparison with no treatment, immunosuppressive agents like azathioprine, mycophenolate mofetil, and rituximab were able to reduce the risk of relapse. It is also important to note in this analysis, MS disease-modifying therapy was not effective to reduce the risk of relapse. Recently, an Italian group reported that treatment algorithm for long-term management of MOGAD. And if relapsing MOGAD, well, of course, you have to think about long-term treatment. But even if you see a patient with monophasic MOGAD, if the recovery is incomplete from attack onset, and if the patient is steroid dependent, and if the patient has autoimmune comorbidities requiring long-term immunotherapy, and if the patient want to initiate treatment, you may have to think about the long-term immunosuppression. They think that the tocilizumab, IL-6 receptor monoclonal, and monthly IVIG are highly efficacious, and oral immunosuppressive agents, mycophenolate, azathioprine. It seems mycophenolate may be more effective than azathioprine. That may be moderate to high efficacy. But rituximab may also be a choice, although they are a bit less efficacious. And for some reason, in some patients, even if the B cells are completely depleted, some MOGAD patients may experience relapse during rituximab treatment. And other options include CD90 monoclonal inebilizumab and CAR-T treatment and so on. But I do not go into the detail. Finally, I will, in the last part of my talk, I will talk about ongoing clinical trials. So this is the meta-analysis of the relapse-free rate and the change of annualized relapse rate after the treatment. And it seems, in terms of relapse-free rate, IVIG and tocilizumab seems to be better. In terms of the change of annualized relapse rate, IVIG seems to be better. And as for the tocilizumab, rituximab, prednisolone, this recent study shows that tocilizumab may be a bit better than rituximab and definitely better than prednisolone in terms of the annualized relapse rate reduction. And also, a few years ago, John Chen and the colleagues reported the treatment efficacy of maintenance IVIG to prevent relapse in adult patients. And 59 patients were included, and annualized relapse rate declined from 1.4 before IVIG treatment to 0, while IVIG treatment is done. And about 1/3 of the patients had at least one relapse. And as for the doses of IVIG, high doses, which is 1 gram per kilogram every 4 weeks or more, was more effective than low dose in terms of the relapse prevention. And IVIG seems to be effective in children as well. In this treatment, IVIG and immunomodulator treatment like mycophenolate and azathioprine were compared, and it seems the annualized relapse rate was lower in IVIG group than immunosuppressive agent only group. Although in both groups, in comparison with before the treatment, during the treatment, there was a significant reduction of relapse rate. But this Kaplan-Meier curve showed that IVIG seems to be more effective than immunosuppressive agent alone to prevent the relapse, to prevent the first relapse. There are two ongoing clinical trials that we are participating in. So one is COSMO, which is a rozanolixizumab, which is a neonatal Fc receptor antibody to reduce the amount of pathogenic MOG IgG. Another one is Meteoroid, which is a satralizumab trial. Satralizumab is IL-6 receptor monoclonal, and both are international randomized control trial, and the primary endpoint is time to relapse. And Meteoroid results will be obtained quite soon, and in the upcoming AAN, the top line results may be reported. But finally, it's important to note that the early start of the acute phase treatment in this study, 7 days or less, and the longer corticosteroid treatment, 5 weeks or more, were associated with a lower risk of relapse. And the similar result was reported by the Korean group. If you start the onset event treatment less than 5 days in comparison with later treatment, you can reduce the risk of relapse significantly. And needless to say, non-steroid immunosuppressive maintenance treatment was effective to reduce the risk. And the Australian group recently reported that if you treat the patients with 12.5 milligram or greater dose of corticosteroid for at least 3 months, in comparison with untreated patients, there was a nearly 90% risk reduction of relapse. And the similar results were reported by others. So it seems early treatment and maintain the treatment for some time are important to inhibit persistent autoimmunity to MOG, which is probably related to the risk of relapse. And finally, Australian group recently reported the meta-analysis of the biomarkers to predict relapse in MOGAD, and they reported that if the patients are persistently positive for MOG IgG, there's a higher risk of relapse. And in monophasic patients and the relapsing patients, in monophasic patients, they may revert to seronegative MOG IgG quite often in comparison with relapsing cases. And as for the association between the biomarker and attack disease activity, higher antibody titers were associated with the higher disease activity, and the CSF white cell counts are higher if it's associated with the higher disease activity. So they concluded that MOG IgG serostatus, titers, and the CSF leukocytosis are the biomarkers of disease course and activity, and they recommend to test serum MOG IgG every 3 to 6 months in the first 12 months of the disease. So this is my summary. So for acute attacks and relapse preventions, a number of different treatment options are available, but more therapeutic evidences are needed. With that, thank you very much for your attention.
If there are any questions from the audience? Professor Tahir. Professor Tahir Aziz is Professor of Immunology at Shifa International, my parent institute as well.
Thank you.
Thank you very much, Professor. Especially the last slide was very exciting. I was thinking that when looking at biomarkers for possible relapse, one is the quantitative analysis, the titration of MOGAD antibodies. That is one, as you suggested. I was also thinking about measurement of CH50 in relation to complement and the metabolism byproducts, C5 to 8 measurement as a measure of consumption. But those two measurements only in that restricted area where the pathology is going on. That is if we can somehow sample the most relevant fluid instead of just taking peripheral blood that would be mixed with so much of everything else. So these three things combined are likely to give a more accurate assessment of underlying damage, and thus will help in correct assessment of patients who are going to benefit.
Well, thank you very much. I think, yeah, you're completely right. And as I presented in my slides, and so we also showed that membrane attack complex C5b9, if they are higher, they are more likely to be associated with severe disease. But as for their relationship with relapse, I do not have any data. And of course, to evaluate the risk of relapse, I think the biomarkers measurable in the blood may be more useful for this kind of analysis. So as for complement components in the blood, I think more studies are probably needed. Australian group reported that blood complement components are also very high. But as for the long-term significance in terms of the relapse prevention, relapse prediction, I think more studies are needed. But thank you very much for your question.
I'm Dr. Haris here, Professor Fujihara. First of all, I would like to thank you on behalf of PATKRIMS for an insightful talk. So I have a couple of questions. First is, how frequently do you see MOGAD in your Japanese population? So just to give you a context, so the center where I'm working, we have in the last 8 years about 300 MS patients versus about 100 NMOSD and around 30 MOGAD patients. So what is the frequency that you're seeing in number terms?
Okay, well, thank you. Based on the recent nationwide epidemiological surveys, we have about 20,000 MS patients in Japan. And as for NMOSD, 6,000 to 7,000. And as for MS, 2,000 or so. So just like your situation, MOGAD is much less frequent than NMOSD and MS. However, I think that even now, the MOGAD is still underdiagnosed because one thing is MOGA IgG detection assay has never been standardized. So it could be positive at laboratory A, but negative at laboratory B. And as I mentioned, over time, even if the patients are initially positive for MOGA IgG, over time, it may convert to seronegative, as I showed you in my presentation. And also, there are a number of reports, including ours, that MOGA IgG may be detected only in the CSF, but seronegative. So if you test only serum, you may miss the diagnosis. So still now, I think the MOGAD is very much underdiagnosed.
So my second,
yes, please.
My second question is, how do you navigate this tendency or likelihood of starting preventive medications after a first attack of severe MOGAD associated, let's say, transthoracic?
Right. Yeah, that's critically important question. And so, as I said, not all MOGAD patients experience relapse. So in those patients, if you can predict a relapse risk accurately for patients who are likely to have monophasic course, you may not want to start long-term immunosuppression to prevent long-term side effects of the treatment. So in that context, a recent meta-analysis reported by Australian group is quite important. So the MOG-IgG serostatus, if it's persistently positive, you may have to think about the long-term immunosuppression, but it's still not 100%. If it's high titers, the disease activity may be high. And if the initial CSF white blood cell counts are high, it may also be associated with a higher risk of relapse. But in terms of the clinical phenotype, probably many of your patients with relapsing MOGAD has optic neuritis. But on the other hand, transverse myelitis in MOGAD is much less likely to relapse. So depending on the clinical phenotype, the risk of relapse may be different. So those are the things that should be considered in considering the relapse prevention. But as I mentioned in the Italian group's treatment algorithm, even if the patient has only one episode, most experts think that if the onset event is severe, then we may need to think about the long-term immunosuppression from the beginning, because another attack may be devastating.
Professor, I have a question that
Yes.
you referred to one of the study in the Australian group, which was heading the MOGAD treatment. You said the treatment, they used only steroid in a dose of 12.5 and high. So what was the rationale about that? What was the rationale of that treatment?
Well, so they analyzed their data based on the dose and the duration of the corticosteroid treatment, but it does not necessarily mean that they treat the patients with a corticosteroid all the time. I firmly believe that they have treated the patients with other immunosuppressive agents, but for initial attack, probably the IV methylprednisolone treatment was followed by probably the tapering doses of corticosteroid. Then they analyzed the data and found that 12.5 milligram or greater dose of daily corticosteroid for at least 3 months was able to greatly reduce the risk of relapse. But as for long-term treatment, I think they have tried a different type of immunosuppressive agents as well.
Thank you, Professor Fujihara, and we really appreciate all your efforts that you have done so far for CNS demyelination. And I'm sure you're one of the most looked up celebrities of neurology on the internet. And I'm one of your fan as well. And also thank you very much for giving us a hard time learning all the new diagnostic criterias every now and then. Thank you very much.
Thank you very much.
So moving on to our next speaker, we now have Dr. Tahira Mohammad, and she's an immunologist from Shifa International Hospital, and she will talk on the anti-MOG associated disorders in Pakistan. And after that, we will go for a tea break and end the session number 1. Thank you.
Assalamu alaikum and a very good morning to everyone. First of all, I would like to thank the organizers of PATKRIMS for inviting me so I can share our work. I'm also grateful to my supervisor, Professor Dr. Tahira Aziz Ahmed, Head of Department Immunology, as well as Professor Dr. Arsalan, Head of Department Neurology, Shifa International Hospital, who supported me and mentored me throughout the study. So today I will be sharing our 5-year data on anti-MOG antibody-associated disorders from Pakistan, which is the largest to date And although it is increasingly recognized worldwide, there is a scarcity of data from Pakistan, and we aim to fill in that gap. So I have no disclosures. So myelin oligodendrocyte glycoprotein, it is a component of myelin. Antibodies against this is associated with a MOG antibody-associated disease, and this can present as optic neuritis, transverse myelitis, and ADEM. This can occur alone or in combination, and it usually presents as a monophasic or as a relapsing course. Coming to the epidemiology, worldwide prevalence is about 1.3 to 2.5 per 100,000. Worldwide incidence was shown to be 3.4 to 4.8 per million per year. A Thailand population-based study showed prevalence of 0.5 per 100,000, and a Malaysian national data showed prevalence of 0.1 per 100,000. For Pakistani and neighboring South Asian countries, there is a lack in published data on incidence and prevalence to date. So this slide just to show you the 5-year data from Shifa International Hospital on the frequency of different antibodies. As you can see, there is the most increased frequency against anti-NMDA receptor at 47%. This is followed by anti-aquaporin 4, anti-MOG, and anti-Titin more or less 15%, followed by anti-Casper receptors and anti-LGI1 at 14 and 13% respectively. I'd also like to point that we were the ones who published the first case report against anti-AMPA receptor encephalitis from Pakistan, case report in JPMA, so if you'd like to have a look. So there's the 2023 proposed diagnostic criteria by Brenda Brendwell et al. So they proposed that the diagnosis requires at least core clinical demyelinating event, which includes most frequently optic neuritis, transverse myelitis, and acute disseminated myelitis most frequently, and sometimes cerebral monofocal or polyfocal deficits, brainstem or cerebellar deficits, and cerebral cortical encephalitis. Then we also need a clear positive MOG IgG test, most preferably on a cell-based assay and using the serum, and then the exclusion of a better diagnosis. In cases where the MOG IgG test is not clear, or there's no reported titer, or it's only positive in the CSF, then we would require additional supportive clinical or MRI features. So the supportive features for optic neuritis would include bilateral simultaneous clinical involvement, longitudinal optic nerve involvement, perineural optic nerve sheath enhancement, and optic disc edema. For myelitis, you would need longitudinally extensive myelitis, central cord lesions or axial H sign on imaging, and conus lesion. And for brainstem or cerebral syndrome, you would need multiple ill-defined hyper to intense lesions in the supratentorial and often infratentorial white matter, deep gray matter involvement, ill-defined T2 hyperintensities involving the pons, middle cerebellar peduncle or medulla, and cortical lesions with or without lesional and overlying meningeal enhancement. Just a summary here to show the differences between 3 demyelinating diseases. So for MOG, you can see there's usually a common antecedent infection or immunization. Age, it affects all ages. The gender, they say there is no gender bias for MOG, and there is for aquaporin 4 positive as well as multiple sclerosis. There's no definite epidemiology according to geographic or ethnicity. However, the prevalence is more common for MS. Then for the course of disease, it is monophasic or relapsing for MOG. And for CSF oligoclonal it is more common in multiple sclerosis at 85% and only 5 to 20 for MOGAD. And the blood biomarker is available for MOGAD and aquaporin 4, but not so for multiple sclerosis. This is our study which we published in JCPSP. anti-MOG antibody-associated disorders from Pakistan, so please have a look. The objectives of our study were to present the clinical pathological features in the local population, as well as treatment outcomes in patients who tested positive for anti-MOG antibodies. After approval from IRB, we conducted the test between January 2018 and December 2022. The method we used was indirect immunofluorescence on EU90 cells transfected with MOG genes. Our inclusion criteria were patients of all ages, inpatient and outpatient, as well as both genders, and positive for a MOG IgG. And our exclusion criteria were the patients whose clinical details were not available. And the data collection was done via a structured questionnaire. So we had a total of 740 patients who tested for anti-MOG antibodies. Out of these, 626 patients were negative. 114 patients were seropositive for anti-MOG antibodies. Out of these, we had 81 patients who were also negative for aquaporin 4 antibodies. Out of the 114 positive patients, 55 patients were excluded, 53 because the details were not available, and 2 expired. And then we were remaining with a total of 59 patients who were included for final analysis. So just briefly to show you the technique of indirect immunofluorescence, we have these commercially prepared slides which have antigen fixed to the surface. It is a two-step process. First, we incubate the slides with the antigens fixed on top with the patient's serum. And if the serum has the antibodies present, then they will bind to the antigen. Then in order to view these bound antibodies, we then add another fluorescein conjugated secondary antibody against human IgG. And if then we view this under the fluorescence microscope. So the sensitivity of this test is 95% and specificity is 84%. So this is exactly what the slide looked like. There's like 5 sections. Each section has 2 biochips, one for the negative control and one for the patient's sample. And this is exactly how it looks like under the fluorescence microscope. You can see here in a negative control where there is no staining, and over here this is a positive patient's control at a dilution of 1 to 10, where you can clearly see the bright green fluorescence and accentuation of the cell membrane. So our data showed a frequency of 15%. The mean age was 24 years and 68% were males. The most common clinical features were vision loss for 39 patients, limb weakness for 36 patients, headache for 30. This was followed by tingling, nausea, vomiting, constipation, back pain, urinary retention, ocular pain, seizures, urinary incontinence, and altered mental status. So vision loss was found to be bilateral in 72% and unilateral in 28% of the patients. The pattern of weakness which we saw was 58% showed paraparesis, 28% quadriparesis, 8% showed lower limb monoparesis, and right and left hemiparesis were 3% each. Other investigations which we carried out were for oligoclonal bands, where we had intrathecal synthesis of IgG in only 2 patients, and visual evoked potentials, where there was bilateral dysfunction in 8 patients, unilateral in 3 patients, and 2 patients had a normal test. Now coming to the treatment given, the most commonly treatment which was given to the patients was oral and IV steroids, followed by azathioprine. There was a combination of first and second line therapies. When we look at the outcome, we can see that 27% had full recovery. And out of these patients, there was no symptom recurrence. And their treatment included a combination of IV and oral steroids, plasma exchange, and azathioprine. And then we had 49 patients who only showed partial improvement. On our follow-up, the first year follow-up, we had 10 patients who showed full recovery and 18 patients who showed partial improvement. Then on the 2-year follow-up, we had 4 patients with partial improvement and 2 patients with full recovery. The 3 years, we had 3 patients with partial improvement and 1 patient with full recovery. On the 4-year follow-up, 3 each for full and partial improvement, and at 5 years, we had 1 patient with partial improvement. Now, a comparison of our data with published international journals. So if you look at the mean age, ours is comparable throughout with all of the other publications from India, China, Sri Lanka, and the US, except for this one study from India where their mean age was 12.5 because their cohort included more children. Then if you look at the gender, we had more males, and this is comparable with the study from India. However, it differed from the other studies from China, Sri Lanka, and USA, which showed more of a female predominance. Optic neuritis in our study is comparable to the study in India. Transverse myelitis is also comparable to the study from India and differs from the studies from China and the US. And ADAM is also comparable to the study from India, and it differs from the study from the USA. So our study had some limitations. That is a limited sample size, single center data, which did not reflect the national prevalence. Some cases lacked complete clinical details, and the disease status and sampling may have influenced the recall accuracy. In conclusion, I'd like to state that the most frequent presentations we saw were optic neuritis, myelitis, and ADAM, which were seen in children less than 12 years. They may occur alone or in combination. They affected both children and adults, and a specific treatment is vital as there was a favorable response to treatment. Thank you. Sir, in the follow-up, I did not find any, no relapses, no.
Are there any cases of anti-alcohol?
No, they were negative. No, I didn't have a double positive. No, they had, the ones who did have aquaporin 4, they were all negative. 81 were negative out of the 114 positive.
Are there any false positive patients? False positive patient?
No, we don't have any false positive. We followed the criteria, and we checked their anti-MOG antibodies were as +1, +2, and +3 on the immunofluorescence test, along with the criteria for transverse myelitis or optic neuritis. So. Yes, sir, we had inpatient and outpatient, both.
Okay.
Yeah.
Just the antibody test, most of the antibodies tests which are reported at low levels, they're really the physician's clinical decision matters. And that's the area, if we look deeper into it, one may find that low levels are there and the clinical picture is not supporting that.
We've published a case of Cryon maybe 4 or 5 years ago with multiple relapses. And we did the MOG antibodies maybe 4 times. Each time it was negative. But when we published it, it was negative. But then the patient gave up all the medications. She stopped her rituximab, she stopped her steroids, went on some Hakimi treatments. And then she had a major relapse. And she came very quickly. The problem with MOG antibodies is, as the other speakers have mentioned as well, is that the titers are mostly detected in the first 5 days. अगर इस पे डेटा भी है, पब्लिश डेटा भी है कि फर्स्ट 5 days में अगर आप कर लें, you have a much higher chance of detecting the MOG antibodies. क्योंकि वो फौरन आ गई, उसको पता था कि उसने दवाई छोड़ी हुई है और हमें बताया नहीं था. तो हमने जो है before starting the IV methyl pred, I sent the MOG antibodies and they came out strongly positive. तो वो एक केस है क्रायोन का जिसके अंदर शुरू में MOG antibodies पॉजिटिव नहीं आए क्योंकि पेशेंट्स को पता होता है कि ये सिम्टम ऑनसेट हो रहा है और फिर वो दे टेक स्टीरॉइड्स, इधर ओरल स्टीरॉइड्स हमको बाद में बताते हैं जब वो ठीक नहीं हो रहे होते. और बाय दैट टाइम इम्यूनोथेरेपी भी ले चुके होते हैं, वो टाइम गुजर चुका होता है डिटेक्शन का. सो एक्वापोरिन 4 के साथ ये इशू नहीं होता, लेकिन मॉग के साथ ये होता है कि आप कोशिश करें कि जिस तरह अर्ली मॉग टेस्टिंग इज इम्पॉर्टेंट एज इज द अर्ली ट्रीटमेंट, क्योंकि अर्ली फेज में ही मॉग एंटीबॉडीज भी ज़्यादा होते हैं और वो ट्रीटमेंट रिस्पॉन्स भी बेहतर होता है. अच्छा, so any questions?
चेक करना चाहिए और ये बात छोड़ देना चाहिए, लेकिन जिस आमतौर पर देखा जाए कि कुछ या एनएमओ या फिर कटक इश्यू आता है, ज़्यादातर हम पूरे बॉडी और पॉल्यूशन वेट दिखाते हैं. ये एंटीबॉडी भेजने का चेक करने का इतना बहुत ही काम है. प्रॉब्लम ये है कि जैसे एक ही में नहीं होती है ना,
हमारे पास होती है,
के पास होती है, तो जहाँ होती है उनका आसान होता है, तो जहाँ होती नहीं है उनको फिर आपको ना पेशेंट को थेरेपी देना पड़ता है कि वहाँ ले जाके डेमो करवाओ. और कराची में एक लैब है जो करती है, वो भी आउटसाइड.
तो आप हमारी लैब में भेज दिया करें, हम लोग भी बहुत सारी चीज़ें आपकी लैब में भेजते हैं. Professor Tahir is here, maybe. Okay, so before we, I think there are no further questions. Thank you, Dr. Tahira.
Okay, thank you.
So I'll ask my co-chairs for their comments on the session, and then we can close the session.
Thank you. Assalamu alaikum. Thank you for having me here. This is Dr. Waqar Hafiz. I'm a neurologist in neurospace. I think it was a great session, starting from Professor Wasay, detailing the history of MS in Pakistan and how it's going right now. And then followed by Dr. Burhan Chaudhry, who elaborated on the CAR T cell therapy very nicely and how things are progressing in that. And then Professor Fujihara about the MOGAD spectrum. And finally, Dr. Tahira from Shifa. Thank you very much, all of you. I think it's important to know how the history has progressed in the last couple of decades, from therapies that started with interferons and interleukins to immunotherapy and finally CAR T cell therapy. So I think, in my opinion, it is extremely important to know the basics of neuroimmunology and how that works, and for better treatment of the patients. Thank you.
Like disease modifying therapy. Yeah.
Assalamu alaikum. Assalamu alaikum. Excellent talk by the Dr. Wasay, Dr. Burhan, and Dr. Tahira. And well-prepared slides and very concise and excellent. They answered questions in a very wonderful tone. That's wonderful.
So I am Dr. Fareen. I have just one comment. So I was recently in Istanbul with Dr. Dureshahbar in Istanbul MS days. So we got to know what is happening in MS in our neighboring countries, and we realized that, even in India, there are dedicated MS centers. They are doing neurofilament testing. Even in Dhaka, they have all the MS medications where we have only ocrelizumab and, so there's a lot which needs to be done in MS patients. And Dr. Wasay rightly pointed out there's need for more studies, more data, and more. I think what we need to do is develop more MS centers. We don't have a dedicated, even a single MS center. So if we have more MS centers, dedicated centers, then obviously the treatment and the care of the patients will improve.
Thank you very much. We are already late, and I think we should close this session.
Thank you very much. This brings us to the end of session 1. I would now like to invite Professor Mazhar Badshah to please come on the stage for the distribution of certificates. The certificate will be awarded to Professor Wasay. Dr. Tahira Mohammad. Our worthy co-chairs, Dr. Sarmad Ishtiyaq, Dr. Farheen Niazi, Dr. Waqar Hafiz, and finally to our chair, Professor Arsalan Ahmed. So we'll now take a quick 5-minute tea break, and then we'll proceed with session 2. And since this is a neurology conference, so caffeine is not optional. See you in 5 minutes.
Hello. Check. Hello.
Assalamu alaikum. We would like to formally start the session 2. I would request you all to please be seated. Bismillahirrahmanirrahim. So now we formally begin the session 2. For session 2, we have our chair, Professor Dr. Mazhar Badshah, ex-head of department, PIMS Islamabad. And in co-chairs, we have Professor Mansoor Iqbal, who is the head of department, Pakistan Institute of Medical Sciences, Islamabad, and Professor Riaz Mahmood, who is the head of department in Federal General Polyclinic. So the first presentation is by Professor Ali Yusuf, who is working in Shifa, Karachi. And the topic is Mystified Phases of Autoimmune Encephalitis, MRI-based approach.
इससे आगे होगी इससे क्या होगा और इससे पीछे जाएगी और कोई वो मिल सकता है मैं पॉइंटर की बात कर रहा था ठीक वो पॉइंटर कहाँ से बड़े वाला Bismillahirrahmanirrahim. I'm Colonel Yusuf. I'm a consultant neurologist and a neuroimmunologist. Presently, I'm working at PNS Shifa Hospital, Karachi. Today, I'll be discussing mystified phases of autoimmune encephalitis. That's the topic of my discussion.
And this all is basically a newer sort of a classification, which I have made it myself by seeing autoimmune encephalitis in last 10 years. So how you differentiate between various autoimmune encephalitis is basis on various presentations. So what is autoimmune encephalitis? As we all know, यहाँ पे नहीं चल रही. अच्छा, ये थोड़ा slow है. अच्छा, okay. So autoimmune encephalitis is a group of neurological disorders, as we all know, characterized by brain inflammation in which the various antibodies, they attack the immune system and they attack the brain own cells. So what are the various phases of autoimmune encephalitis in which we commonly encounter? So the most common presentation is basically a neuropsychiatric presentation, followed by a peripheral neuropathy pattern. They can present as a progressive cerebellar ataxia, a basal ganglia pattern manifesting as catatonia or rigidity, NORS or focal epileptic pattern. They can present as a sleep disorder purely or a Parkinson disorder, that is a rapidly progressive Parkinson disorder. Some of the autoimmune encephalitis, they can present as a chronic diarrhea, and few have got autonomic dysfunction as well. NORS, as we all know, is a new onset refractory status epilepticus in which there is no identifiable reason. Then they can also present as a muscular dystrophy, myopathic pattern, acute lumbago, like stiff person syndrome. They have got ANA, ALS like phenotype as well. Couple of autoimmune encephalitis, if they are not treated in time, they have a neurodegenerative pattern. Sometimes very difficult to differentiate autoimmune encephalitis, the first attack of autoimmune encephalitis, from acute meningitis or acute tuberculous meningitis. They have got neuromuscular junction associations as well. I'll come one by one on these. So the most common presentation is basically a neuropsychiatric, as we all know, and NMDA is the most common autoimmune encephalitis. There are a couple of new encephalitis like Neurexin 3 alpha and EMPA. EMPA is not very common, but NMDA is the most common autoimmune encephalitis, and followed by Neurexin 3 alpha. In NMD encephalitis, as we all know, there is history of ovarian teratoma in more than 50% of the patients. The antibodies are against the glutamate receptors, the NMD receptors on the postsynaptic neurons, and they can have pure psychiatric manifestations. Initially, they usually report to psychiatrist, followed by a neurologist when there is seizures or frequent movement disorder, especially orofacial dyskinesias. So it can have this subtle sort of, in 70% of NMD encephalitis, usually the MRI is normal. You can see that there is involvement of subtle left basal ganglia hyperintensity in NMD encephalitis. This is one of the case of NMD encephalitis. On the right side, you can see that at the onset, you have got mesial temporal hyperintensities, and a 3-year follow-up, the patient was, if left untreated, it resembles mesial temporal sclerosis or MTS. Neurexin 3 alpha is a newer encephalitis in town. It's basically autoimmune encephalitis, also known as a post-infectious encephalitis. This antibody is not commonly available, not available with us, but we suspect in patients who have got a typical manifestation of NMDA and they are NMDA negative. So always think of Neurexin 3 alpha. It's followed by a upper respiratory tract illness. Symptoms are more or less similar to NMDA encephalitis, plus a central hypoventilation syndrome because of the frequent brainstem involvement. Neurexin 3 alpha MRI closely mimics herpes encephalitis MRI. You can see multiple hyperintensities in the cortical, subcortical area, insular ribbon area, and as well as in the frontal cortices. So sometimes very difficult to differentiate Neurexin 3 alpha from herpes encephalitis, clinically as well as radiologically. Then we have got the EMPA encephalitis. EMPA encephalitis presents again as a neuropsychiatric manifestations. 70% have got underlying tumor like thymoma or lung cancer. And the good thing is if you remove the tumor or start steroids and treatment earlier, the response rate is very good. 70% respond to immunotherapy or tumor removal. There are a couple of negative factors, like if the patient has got other antibodies like SOX antibody, amphiphysine or CRMP5, the response rate is not as good. I have got the only one case of in Pakistan of MPI encephalitis, which I'll be discussing at the end of my presentation. So they can start with a behavioral change, seizures, confusion, and disorientation. MRI, this is the MRI of MPI encephalitis. You can see cortical, subcortical changes, left basal ganglia and right basal ganglia involvement and anterior temporal lobe involvement. So this is a non-specific white matter involvement. So here we can't say MPA or any encephalitis based on his MRI, but this is a non-specific gray and white matter involvement in cases of MPA encephalitis. So the other common presentation is a peripheral neuropathy-like pattern, and the prototype is anti-Khyber encephalitis followed by anti-MOG. So Khyber is basically a potassium channel encephalitis in which Khyber and contactin, they make a union and ultimately affects the potassium channels. They can present as a rippling muscle disease. Here we confuse these sort of patients with the peripheral neuropathy or ALS-like patients, and we confuse this rippling with the fasciculations of amyotrophic lateral sclerosis. So it involves both central and peripheral nervous system, and it can cause psychiatric and neurological manifestation, but the main hallmark is basically rippling muscle disease. MRI shows left bulky medial temporal lobes on the left side in this slide, and bilateral temporal lobe involvement more on the left side. Then anti-MOG encephalitis, much has been already discussed, but they can have a central as well as a peripheral nervous system involvement. And I have got a couple of cases who had pure peripheral involvement. It's not transverse myelitis, it's basically a peripheral neuropathy because anti-MOG antibodies, they attack your peripheral nervous system as well. So apart from backache, blurring of vision, they can also present as peripheral neuropathy. So this is a typical MRI of a MOGAD patient showing extensive white matter, gray matter lesions, and encephalomyelitis-like presentation. You can see there is involvement of cerebellar peduncles, cortical and subcortical distribution, various lesions, and follow-up MRI, the lesions increased because this patient was not treated adequately. The third commonest manifestation of autoimmune encephalitis is a progressive cerebellar ataxia, and this is the most important thing because they attack your Purkinje cell antibodies. So I divide cerebellar ataxia, also known as a progressive primary autoimmune cerebellar ataxia, PACA, known as PACA. We are dealing with a paraneoplastic or a non-paraneoplastic focus. Among the paraneoplastic focus, anti-HOMER3, this is a new emerging antibody. Testing is available, not here, but it is one of the commonest antibody, and followed by a neurochondrin. These are basically two non-paraneoplastic antibodies. Regarding paraneoplastic antibodies, we all are very much familiar, like anti-HO, anti-U, anti-PCA1, PCA2, and there are a couple of new antibodies I'll be discussing, like seizure-related and Calch-like 11 antibody, which are newer in town, which have got a paraneoplastic encephalitis, and they can present as a progressive cerebellar ataxia. Few words regarding anti-HOMER3. Anti-HOMER3, the most important thing, it is a MSA mimicker. So I have got couple of patients who had a progressive cerebral ataxia, who has MRI is very, very pathognomonic of MSA. There's a typical cruciform appearance of the pons, and followed by pontocerebellar atrophy, which we usually encounter in MSA. And they responded very, very well to corticosteroids and further immunotherapy. So ataxic signs are present in anti-HOMER3, and symptoms are basically because of the Purkinje cell involvement, nausea, vomiting, typical cerebellar involvement. History is definitely subacute to acute. Here you can see involvement of the cerebellum, cerebellar peduncle, cerebellar folia, couple of contrast enhancements at the base of, over here. And mostly the lesions and over here as well, probably in the last, if I'm this over this area. So this is in acute phase, but in chronic phase, it can cause cerebellar and pons atrophy with, I have already mentioned, with a typical neuroimaging of MSA. Anti-Ho, anti-U antibodies, we are very much familiar. They have got a paraneoplastic association. Mostly they are related to either CA lung, CA ovaries, or gynecological carcinomas. Among them, testicular seminomas are associated with anti-Ma and anti-Ta, and they have got a high risk. They can either present as a cerebellar manifestation, or they have this opsoclonus myoclonus syndrome, which have got a poor prognosis. There are a couple of B-cell mediated antibodies at the bottom, that GABA B, Casper, DPPX, and LG1, which have got a low tumor risk and a good response to corticosteroids and further immunotherapy. So here you can see in acute setting, there is involvement of the cerebellum. There is hyperintensity over here. In long-standing, you can see this is progressive cerebral atrophy. You can hardly find any cerebellum with because of the Purkinje's involvement. In acute setting, there is a contrast enhancement over here. Anti-Kelch-like, this is basically a neuroantigen which is associated with testicular tumors. I don't know because I haven't found any test positive with me, but it's a neuroantigen in town. And the symptoms are basically either progressive cerebellar ataxia and sleep disorder. This is a second autoimmune encephalitis apart from neurexin 3 alpha and one of the encephalitis known as IG LON, which can cause the sleep disturbances or sleep-related disorders. This is the one of the commonest manifestation of anti-Kelch-like antibody syndrome known as Ondine syndrome, which is known as Ondine curse, which causes sufferers to die if they fall asleep. So there's central hypoventilation. Condition results for damage of the brainstem and cerebellum, also known as rhomboencephalitis, caused by autoimmune inflammation of the cerebellum. So again, you can see multiple white spots in the brainstem, non-specific white matte spots in the mesial temporal lobes, periventricular demyelination. Sometimes you can see that these lesions are mimicker of multiple sclerosis, but the history is usually short, and ataxia is usually progressive with central hypoventilation, and prognosis is not good because in MS, your prognosis or the relapse rate, it improves much more comfortably with steroids as compared to this sort of encephalitis. Then we have got the seizure-related 6 homolog 2 encephalitis. This is again a new entity in town. It can present with a cerebellar ataxia. And the second important thing is Parkinson and related disorders. And it has got a strong association with carcinoma of lung. On the left side, you can see that if left untreated, even after tumor removal, the prognosis is not good in this sort of encephalitis. You can see pontocerebellar atrophy. There's flattening of pons, and there is atrophy of cerebellum with ample space in the posterior fossa. Basal ganglia pattern, NMDA, already know they can present as acute dystonic reactions, orofacial dyskinesias. They can have a catatonia. I have one patient with me at PNS Shifa right now who has NMDA positive, and he's catatonic. In spite of all my treatment, rituximab, he hasn't responded to any of the treatment, and now he is undergoing ECT with minimal improvement. Then AMPA, already discussed, and then TG6 encephalitis. TG6 encephalitis is an encephalitis which is associated with gluten-related issues. It can cause cerebellar ataxia, and it can cause a basal ganglia encephalitis. TG6 stands for transglutaminase 6 Ig antibody in the serum and cerebrospinal fluid, which account for 15% of all the ataxias. So MRI shows progressive cerebral atrophy or white matter changes. Autoimmune encephalitis can present as LG1 encephalitis or a progressive hemispheric or unilateral faciobrachial seizures. This is the second most common encephalitis apart from NMD encephalitis. 50% of the patients they present with, it's usually occur in elderly males, and 50% of the patients they present with faciobrachial seizures that are refractory to conventional treatment, followed by autonomic dysfunction. And hyponatremia is basically the hallmark of this sort of encephalitis. Hyponatremia is basically related to antibody binding with ADH receptors. Then ultimately cognitive decline. The good thing about this sort of encephalitis is it has got less tumor association. It's highly responsive to steroids and further immunotherapy. So if you find any person who has got a faciobrachial seizures sort of thing and followed by a hyponatremia, always think of LG1 encephalitis. MRI is very, very much typical of rest of the autoimmune encephalitis by involvement of the mesial temporal lobes. You can very much appreciate that hyperintensity is in bilateral or unilateral mesial temporal lobes, not typical of herpes because anteriorly there is no involvement of the cerebral cortex. So autoimmune encephalitis can have Parkinson-like presentation. This is another mystified phase. The most common is IG-LON, which is probably the mother or most evil autoimmune encephalitis I have ever encountered. My colleague, Dr. Wasim Ali, probably will enlighten us more about this autoimmune encephalitis in the next presentations. Then we have got neurexin 3 alpha, which I have already discussed. It can also present as a hypoventilative syndromes or Parkinson-related disorders. Couple of words regarding IG-LON. It's basically cell adhesion molecule, and you can see on the left side that it can cause bulbar dysfunctions, movement disorders, cognitive impairment, neuromuscular manifestations, fasciculations in the tongue as well. So it is again a ALS mimicker. History is short. It's basically a tauopathy. Some people believe that this is basic autoimmune encephalitis, or some people believe that this is a progressive neurological dysfunction because of accumulation of tau. That's why initially they respond to steroids, and ultimately the response is much poor. So they can have obstructive sleep apnea. We encounter so many patients because of the rapidly progressive Parkinson disorders who are not responding to Cyanamet and rest of the treatment. Ultimately, they land up with our respiratory colleagues because of obstructive sleep apnea, and ultimately to a neurologist when there are seizures or refractory Parkinson disorder. They have got fasciculations in the tongue and limbs, muscle weakness, and muscle atrophy. MRI is again somehow confusing, but they are large fluffy lesions. In cases of this IG-LON, MRI can be normal as well, but mostly the MRI shows mesial temporal hyperintensities. This is another mystified phase, or I must say this is the most difficult autoimmune encephalitis to diagnose because it starts with a chronic diarrhea. Referred a couple of patients to me by my gastro team. So there is history of diarrhea, weight loss, all the TB workup, whatever chronic diarrhea workup is there. This is negative. The patient usually then develops a CNS hyperexcitability with cognitive decline and confusion and myoclonus. Treatment response is usually not good. It's a subacute presentation of this encephalitis. And this antibody is, we have got here. We can test this antibody in cases of chronic diarrhea. MRI shows large fluffy lesions with mesial temporal Adam-like lesions, cortical, subcortical, and basal ganglia involvement. Autonomic dysfunction is one of the hallmark of autoimmune encephalitis, starting from lambda followed by neurexin 3 alpha, and then the potassium channel antibodies. So potassium channels, they can cause peripheral nerve hyperexcitability, as already mentioned in cases of Casper. Then they have got autonomic instability and then encephalopathy. One syndrome is known as Morven's encephalitis, associated with it with excessive sweating, hyperhidrosis or hyperhidrosis, fever, and they can have significant weight loss and ultimately hallucinations and confusional episodes, and ultimately leading to mania-like episodes. They have got myokymia, neuromyotonia as well because of this peripheral nerve hyperexcitability. Because here you can see that there is involvement of the thalmi and probably hypothalamic area encountered here, which can show which can be the reason of the autonomic nervous system involvement. NOS, already mentioned, is a new onset refractory status epilepticus. Still, NMD remains the top diagnosis, followed by GABA A and GABA B, and then the glutamate receptors. So GABA A encephalitis. What is GABA A encephalitis? GABA A encephalitis is the most common reason after NMD encephalitis of refractory status epilepticus for which there is no reason. So GABA glutamate converts into GABA, and GABA attacks, and through calcium, this becomes hyperpolarized. And if the patient, so this is a common thing, it is associated with thymoma, refractory seizures in cases of 85% of the cases, with cognitive and behavioral involvement, and ultimately being ventilated so many times with a poor response to whatever we do, whatever immunotherapy we use. The GABA A encephalitis is the most pathognomonic of NOS. So MRI shows white matter demyelination in the periventricular area, basal ganglia area. Insular ribbon sign is always look for insular ribbon sign in cases of autoimmune encephalitis, apart from medial temporal lobes. Over here, this basal ganglia involvement over here. So this is autoimmune encephalitis. Followed usually they start with mesial temporal lobes, basal ganglia, and then they involve the insular ribbon. GABA B encephalitis is basically associated with small cell carcinoma of lung. It can present as a rapidly progressive dementia, but refractory seizures occurs up to 5 episodes per day, but it's basically a limbic encephalitis rather than a pure NOS pattern. So MRI shows bilateral medial temporal involvements with amygdala involvement showing limbic encephalitis. Rasmussen's encephalitis, I have got at least 5 to 6 patients of Rasmussen's encephalitis with me. This is basically unihemispheric T-cell mediated encephalitis. Usually occurs in children, which is a drug-refractory epilepsia partialis continua with progressive hemiparesis, cognitive decline, and there is role of functional hemispherotomy in this. The main thing is to differentiate this sort of encephalitis is from CP child. So it have got progressive weakness and cognitive defects. So how you differentiate between CP and it had got 4 stages like cortical swelling and ultimately leading to marked cerebellar or cerebral atrophy in couple of years. So the way to differentiate is because this is a progressive disorder with progressive EPC, but the cerebral palsy patients, they don't have this progressive hemiatrophy. So no single MRI can differentiate between a CP or autoimmune encephalitis. The progressiveness and refractiveness of the seizures that can be of opinion that this patient has got autoimmune encephalitis related to Rasmussen's, that is a glutamate receptor encephalitis. Then another GLUR5 encephalitis, also known as Ophelia syndrome, associated with Hodgkin lymphoma. They starts with memory impairment because of the involvement of the limbic system, refractory seizures, and there's a neuropsychiatric involvement. Stiff person syndrome. Couple of patients, stiff person patients, they present as acute lumbago when you don't find any reason of acute lumbago and the patient is a robotic person. And when myoclonic seizures are the predominant manifestations, always think of stiff person syndrome. Diagnosis frequently thought as frequently as missed as well. So anti-GAD associated antibodies associated and it is associated with type 1 diabetes mellitus and pernicious anemia. Important thing to differentiate between this and a normal is that it is associated with either myoclonus or painful spasm of the muscles. Involvement can be of medial temporal lobes bilaterally. So there is another entity known as PERM associated with anti-amphiphysin, anti-glycine, anti-G5 antibody. These are all paraneoplastic antibodies. In SPS, usually the brain is not involved, but in cases of PERM, the brain is involved as frequently as the peripheral nervous system. So they can present as an encephalopathy along with this rigidity and painful spasm. White matter demyelination, you can't fit in any disorder. So if it's subacute history, always think of autoimmune encephalitis. So ALS-like phenotype, either with a Khyber because of the peripheral nerve hyperexcitability, proximal myopathy associated with Khyber, and the myasthenic patients who have got a strong association with Khyber, and the typical IG Lawn disease, which have also got a ALS-like phenotype. Neurodegeneration, any autoimmune encephalitis, if left untreated, especially Kelch-like and IG Lawn, they can have a neurodegenerative pattern. IG Lawn is most important because it's basically a tauopathy presenting as autoimmune encephalitis. So as already mentioned, that meningoencephalitis pattern, so this is a very, very, very common occurrence. Patient comes with confusion with plus minus history of fever. And if you do the CSF, there are a couple of cells like 150. We start as typical antiviral treatment. If the patient is not responding, we just add antituberculous treatment. This is a common happening. But always think of meningoencephalitis because of this NMDA, Kelch-like, anti-MOG, because they have got CSF that is very much mimicry of this meningoencephalitis because of the these autoimmune encephalitides. So I have got one patient of anti-AMPA encephalitis. This patient was basically diagnosed by Professor Tahira Aziz 2 years ago, and this patient presented with typical neuropsychiatric manifestations followed by limbic encephalitis behavior. I had plexed him twice, no response. In third week, he had bilateral ptosis. Then I scanned him. He has got a thymoma associated with it. So he was anti-acetylcholine receptor antibodies positive. With the help of and early diagnosis, this is the first AMPA diagnosed case in Pakistan. This is short video. I don't know whether it will play. Oh. So this is after 2 years. This is a recently taken picture, that video which showed that this patient has improved tremendously after removal of thymoma, and with immunotherapy. I have given mirvetuximab, so it's a tremendous response, and the family is very much thankful to all of us. This is probably the last slide, which summarizes all sort of encephalitides, which are most common, like NMDA. They can have a typical neuropsychiatric manifestation, usually in females, LG1 presenting as brachiofacial seizures, GABA B and GABA A presenting as NORS, Khyber presenting as a peripheral neuropathy or neuropathic pattern with cramps, MOG as encephalomyelitis with peripheral neuropathy, glycine and AMPA along with hyperplexias, DPPX presenting as diarrhea, and IG Lawn presenting as refractory Parkinson disorder. I thank you all for your patient listening. Yeah, sure.
Thank you very much, Professor Yusuf. We'll take the questions at the end of this session because we're running short of time. So our next speaker is Dr. Ahmad Abdul Aziz Abulaban. He's the Assistant Professor and Consultant of Neurology at King Saud bin Abdul Aziz University for Health Sciences. He's also the Director of Neurology Residency Training Program He is the Chief Coordinator of the Neurosciences and the Vision Block for the medical students. And he's also Research Officer for Multiple Sclerosis Chapter for the Saudi Neurology Society. And the topic for his presentation today is body fluids biomarkers in CNS demyelinating disorders.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Do you hear me? Is the sound good? And do you see my slides? Do you hear me?
Yes, we are hearing you.
Yes, we can hear you.
Okay. Okay, good. So in the next 20 minutes, I'm going to focus more on multiple sclerosis. As you know, multiple sclerosis is a neuroinflammatory and neurodegenerative disease. This is my disclosure. Why do we need the biomarker? You know, in multiple sclerosis, patients can have heterogeneous course of a disease. We see different patients behaving differently. Some patients are doing well, some patients are not doing well. And all what we got is MRI and clinical examinations. We need to have more accurate marker that can help us and maybe better than going through imaging, and hopefully can be done at home based. That is the future. And also we want to get a marker that give us early detections and maybe differentiations with other MS mimicker and maybe also prediction for conversion to progression or prediction of PIRA, which is progression independent of relapse activity, which is now contribute to many patient disability. The main fluid biomarker that I'm going to talk about is the serum neurofilament, which is maybe I'm sure you heard a lot about, which is a marker of inflammations, and it indicate axonal damage and axonal injury due to acute inflammations. The problem with the serum neurofilament, it is not specific. It is very sensitive, but not specific, and can be seen in many other diseases, even not specific to CNS demyelination. It's a good marker to control the disease activity after confirming the diagnosis, but it's not specific. We have other, maybe a better marker for the for neurodegeneration, namely GFAP and Chi3. GFAP is the glial fibrillatory protein, astrocyte protein, and also catenase 3 like protein, which are indicative of neurodegeneration. GFAP is it indicates astrocyte activations and gliosis. Chi3 is more seen with chronic active lesions. So these are evolving new markers for neurodegenerations. Some studies showed, you know, the good correlations with the radiologically isolated syndrome, and patients even before the onset of multiple sclerosis, the serum neurofilament can rise. And you know, in the famous study of the EBV, where it correlate strongly that EBV seroconversions predicted the occurrence of MS disease. That is in a very famous military study done in US, and it also can be seen in radiological resistance syndrome. In one study, up to 1/3 they convert into multiple sclerosis. GFAP can correlate with paramagnetic rim lesion, which is one of the signs of chronic active lesions, where you find iron-laden macrophages. It's hypointense rim lesion that can be seen in susceptibility weighted images or SWAN or echo gradient images. along with the catenase 3-like protein can be in the CSF was not predictive of uh, progressions into MS. In clinically isolated syndrome, serum neurofilament in reflex trial showed increased risk of conversion to multiple sclerosis and also clinically definite MS. The issue with some studies, as you know, the definition of MS and radiologically isolated syndrome and clinically isolated syndrome is evolving over time. So we need to be cautious thinking about this study as the definition of these syndromes, whatever called clinically isolated syndrome now, is not as the clinic CIS like 2 years back or even 10 years back. So we need more studies now. As you know, there is now new criteria for multiple sclerosis published recently and was presented last year. Now we're more dependent on radiological MRI along with the clinical presentation. And now even sometimes we can diagnose MS even without symptoms. So if the patient, for example, having four locations out of 5 topography, now they can be called multiple sclerosis, even with no symptom or classical symptoms or classical relapse. The Chi3 also has a good predictive power for progressions in EDSS over time, and also correlate with different MRI marker in one study. Also, as you know, in the new criteria, they included the kappa-free light chain, which showed similar sensitivity and specificity to oligoclonal bands. I will explain it in the next 3 slides. Some biomarkers can help in differentiating NMOSD from MS by doing the ratio, which really increase the accuracy. This ratio increased in NMOSD way higher than MS and less in MOGAD. So this arrangement can help in differentiating the three. I mean, definitely the presence of antibodies can help, but sometimes it can take longer. And with the wide availability of this marker can help in not only monitoring the disease, but also in differentiating among other disorders. Now, we live in the era of AI and machine learning algorithm with different protein. Different studies showed that not a single biomarker, but combination of multiple biomarker can reach accuracy of 98% distinguishing MS from other mimics. Definitely, this is only in one study. We need more external validations in multiple studies before we adapt these results. And you know, one of the problems with the artificial intelligence is the overfitting, where the model is very well trained to the degree that it memorizes the data. So it do extremely well in your local data or local population, but it does very poorly in other cohorts. So you want the situation when you need an accuracy, not 100%, but you need an accuracy in the 90. That's where it is the sweet spot. Now, when people think about kappa-free light chain, people think you don't need to, when you test for kappa-free light chain, you don't need CSF. Still, you need the CSF. It's similar to the oligoclonal band. The only difference is the oligoclonal band is more qualitative as compared to quantitative in measurement of kappa-free light chain. Kappa-free light chain is just simply fragment of the immunoglobulin. Still, so to measure the kappa-free light chain, you need the CSF, and but what you are measuring is different. Here, looking for the kappa for the oligoclonal band, you run gel electrophoresis between the CSF and serum, and then you compare the bands, either like it's negative or it's positive, like in type 2 or 3, where it's like some bands detected in the serum, but there are unique bands that is seen in the CSF, which is still again be positive. You need 2 or more Now, in type 4, we call this identical bands between the CSF and the serum similar, and type 4 when it's monoclonal bands. Now, if you notice, this is more of qualitative and it is operator dependent. So you need someone to look into the gel electrophoresis to tell you which type and what is the result. Compare this to kappa-free light chain, which is not qualitative, it is quantitative, and it depends on a laser beam that passes through the kappa-free light chain, which is a fragment of the immunoglobulin. And you compare the serum to the CSF, and there are two assay. And as I said, again, it's not dependent on anybody. It is just on the machine, and you compare the reflections based on the serum as compared to the CSF, and it's very quite sensitive and specific as good as the oligoclonal band. There are very few cases where the OCB is positive, but not the kappa-free light chain, and vice versa. But both they can complement each other, and can kappa-free light chain can replace the oligoclonal band. Now, what happened to the serum neurofilament over time? It can increase, as we said, years before the diagnosis of multiple sclerosis, and it is detected to be increased at least 1 month before the new gadolinium bleaching, and it persists up to 2 to 3 months. And as we can see in this graph, the new enhancing lesion, we start to see rise of the serum neurofilament, and there are some cases where the serum neurofilament can be increased even without an enhancement lesion, indicating if it's correlating with clinical symptoms. There is a good increase and higher percentage of increase if the lesion is within the brain stem or the spinal cord, and somehow we don't know why it is less with optic nerve lesions or a relapse. So this is the expected evolutions of the serum neurofilament. When we measure the serum neurofilament, we can depend on a single cutoff, but that contain with good specificity and low sensitivity. If we do a tilted change, we have better sensitivity, and the ideal is to depend on the Z-score, which need more normative data about your normal population, because it's also affected by the BMI and also by gender also. So neurofilaments the biomarkers can be helpful in relapsing, remitting, or secondary progressive MS. Neurofilament is better indicative of active or acute active inflammations, while GFAP and Chi3 is better as marker for neurodegenerations. Also, when we think about the secondary progressive MS, we have active and non-active. You know, some patients with active neurodegeneration, they can have still active inflammations. They have tendency to have relapses and new enhancing lesion. And while some patients, they just continue to have neurodegeneration. The serum neurofilament cannot be of value, and that's really where the GFAP and Chi3 can be of value. There are other markers that can be added, but still need more clarifications in more studies. And again, not only correlation with the MRI, there are studies correlating with the EDSS. Again, NFL is only can predict relapse associated worsening, and as we know now, the neurodegeneration can be measured in two ways: either relapse associated worsening or PIRA, which is progression independent of relapse activity. NFL can be useful in relapse associated worsening, but not with PIRA, which is a very slow. Regardless of a relapse activity, you have slow worsening in time. That's where GFAP and Chi3 really shine. So maybe in the future, we're going to depend on a combination rather than just a single biomarker, and we need to have normative data before we adapt this into clinical practice. You know, despite having a heavy literature about these biomarker, we still need to have local experience in different center before we adapt this in different lab. Now, as I said, now with the advancement in proteomics and metabolomics measurement, now we can reach an accuracy or a very high accuracy in predictions of the different disease and different cohort. And now in this study, they use the machine learning with very high accuracy, but that was like done in 3 studies with good accuracy, but still need to be replicated in other centers. There are also some studies correlating the cognitive dysfunctions with the serum neurofilament and Chi3, and also with tau, the one seen in Alzheimer's disease, which can correlate with slowed cognitions and cortical damage. So we're gonna see more and more studies using a combination, which is better. So serum neurofilament, as I said again, it's seen better with active inflammations and brain atrophy. GFAP seen with chronic neurodegeneration and was seen in one study with central vein sign and paramagnetic rim lesion. Chi3, when combined with CD163 in one study, also showed a correlation with this slowly expanding lesion or the so-called cells. Now, with chronic active lesions, we have either paramagnetic rim lesion or slowly expanding lesion. Slowly expanding lesion, where you see the lesion slowly growing over time. This is the different marker that correlate with chronic active lesion, whether paramagnetic rim lesion or slowly expanding lesions. The Chi3, Chi1 also correlate with more with microglial activation, but still we need more studies. The best studied biomarker is the GFAP, Chi3, and serum neurofilament. There are some studies also correlating with long-term value, neurofilament and GFAP. GFAP correlated with the EDSS score. Chi3 also indicate more indicative of chronic active lesions. We talked about the kappa-free light chain, which is now can be used in replacement for oligoclonal band. Treatment response, these are the medication where serum neurofilament showed correlations. Other still, as we don't have good treatment for neurodegeneration, we have some medications that has been approved and will be approved, but their clinical effect is of modest efficacy. How to use the biomarker? As I said, it can be used in initial assessment and it can be used in stable patients, but we need to build experience and normative data and can be combined with different biomarker to detect disease activity or treatment failure or even risk estimation, for example, in some studies about with PML, for example, which can give you a warning before the patient develop this deadly side effect. It can be very helpful in detecting any complications. This table show other biomarker that was correlated with different MRI. As we can see here, some of them even I did not talk about, but all these need further evaluations and further validations in different studies. The current limitations is that these need to be tested in every center to test for external validations and to create a normal value that is correlated well with BMI and see how can this ratio differentiate between other degenerative diseases. And as we also need to remember that it's also serum neurofilament, for example, can be raised with neuronal damage that is happening to the peripheral nervous system. Now, this slide summarizes all what I said. I mean, you've seen this slide many times. This is the relapsing remitting disease course where the patient can develop a secondary progressive phase, and this is the accumulation of disability over time. You can check the green, which is the neurofilament. This is the peak. This cartoon shows you our best current understanding about this marker, where it can really fluctuate. Now, Chi3 and GFAB, it's more of slow and indicate neurodegeneration. GFAB is more with correlate with the EDSS. Chi3 is more with chronic active lesion. Both can be seen early in the disease and progress slowly over time. Still, real differences between the two cannot be delineated markedly and clearly based on the current study. So as a take-home message, serum neurofilament is a marker of inflammation. GFAB and Chi3 can be a marker of neurodegeneration. GFAB more with PIRA and EDSS progression. Chi3, it's more with chronic active lesions. Thank you very much. Happy to take any questions.
Any questions?
Thank you. Assalamu alaikum. How are you? Now, my question is that how specific this neurofilament is as compared to, because we mostly do oligoclonal bands only. We usually don't do neurofilament testing in CSF. So how specific is CSF neurofilament testing in terms of diagnosis of multiple sclerosis as compared to OCP or other tests?
So let's differentiate a little bit about serum neurofilament. Now, serum neurofilament can rise with any damage. So, and either diabetic neuropathy or GBS or ADEM. So it's not specific, it's sensitive, but it's not by all means specific to MS. Now, with ratio, different other marker can help and differentiate, but that we still need more studies. Now, oligoclonal band, as we know, it is very sensitive, but again, not specific. It can be seen with other disorders of the central nervous system. Oligoclonal band in the literature is positive in 90% of the patients. In our population, it's present in 95. So we have around 5% patient with OCB negative. Just make sure when you say negative, it's not done. The LP is not done immediately after steroid, because this can make the OCB negative up to 3 months after the pulse steroid. Now it comes the differentiation between kappa free light chain and OCB. They can be used interchangeably. They are almost similar. Kappa free light chain is cheaper, easier to be done, and it is a quantitative method, and it's not operator dependent, and you just need the machine that the laser beam comparing fragment of the immunoglobulin between the serum and the CSF. So it is better and more cost effective, and most likely will replace OCB testing worldwide. Now, is it always exactly similar? Now, some studies showing very minor discrepancies, sometimes where OCB is positive as compared to kappa-free light chain. But for the time being, just for practicality, it can, based on the new criteria, it can replace OCB.
I think they have observed the difference in the morphology of neurofilament in Alzheimer's and in multiple sclerosis, and the level. I think the patterns of aggregation also have been found to be different, because I think they do not aggregate in in Alzheimer's, and they aggregate differently in multiple sclerosis, neurofilament. I'm talking about neurofilament.
Yeah, I agree with you. And also, I forgot to answer one of the questions about the Prof just mentioned earlier, is that the serum neurofilament earlier studies were done in the CSF. But now newer studies, it still can be tested in the blood with very high sensitivity assay, where the amount of serum neurofilament is way higher in the CSF as compared in the serum, but still there are new assays that can detect very small level. Sawoma, for example, is one of the machines that can really give very accurate level. Hopefully in the future, patients can do it at home, like the glucose check. That's the future.
So that was an excellent presentation, and we're very thankful to Professor Ahmad Abdul Aziz that he spared the time for today's presentation. He has another presentation that is due in the PATKRIMS shortly after that. So thank you very much, sir.
Thank you very much. Hopefully next year I will be with you physically.
All right. So for the last presentation of session 2, I would like to call Professor Dr. Wasim Wali, who is working in Pak Emirates Military Hospital, and the presentation is anti-IgLON 5.
First of all, I want to thank the organizers for inviting me to this August gathering. I'm really grateful. This topic is very close to my heart. So IgLON 5 disease, still we don't have the test in Pakistan, but I think we need to increase the awareness of this disease. So considering the historical discovery, the first case was published in 2014, although the initial discovery was started in 2010, but the case series was published in 2014 by Dr. Gross and et al. So in the last 10 years, we have increased understanding of this disease. I'll be discussing more of clinical aspects rather than the other aspects, but I'll briefly be touching the other aspects as well. So IgLON 5 disease, these antibodies are detected in serum and by cell-based assays, and their pathogenic role is under investigation. Postmortem tau deposits mainly in hypothalamus and brain tegmentum. There is a combination of sleep parasomnias, bulbar dysfunction, gait instability, cognitive and psychiatric and movement disorders. Incidence is estimated 1 in 150,000. So it affects male and female equally. And basically, the age group is between 45 and 75 years of age, but it can affect any age group otherwise. Only 10% of the patients, they have associated autoimmune diseases, and it's definitely not paraneoplastic because history of malignancy is only in 11%, which is compared to normal population. So we know the structure, but the exact function of IgLON 5 is still not known. But there are hypotheses. It regulates the adhesion differentiation myoblast. It plays a role in CNS development and regulation, but the exact function we still don't know. So pathophysiology, I'll be briefly discussing. There's antibodies against neuronal surface antigen, and there's a robust association with HLA-DRB1001 and HLA-DQB1 501. So this has a very strong association with IgLON 5 disease. Now it's 2% in general population versus 60% in the IgLON 5 group. So it's a tauopathy. Ultimately, it gets converted to tauopathy, and this tauopathy is different from the other traditional tauopathies. The patients who have HLA positive, they are at the time of diagnosis, they are of younger age. And in the HLA DRB1001 positive patients, they are more prone to sleep abnormalities, brainstem dysfunction, and autonomic dysfunction. And the negative group, cognitive impairment is more. probably triggers, we still don't know the triggers, but probable triggers are HLA genotype, viruses, and tumors. These triggers, they induce B-cell immunity. There's important role of IgG4, although IgG1 is also present in all the patients, but the predominant role is of IgG4. So it's a IgG4 disease. So now this inflammation, this crosses the blood-brain barrier. Ultimately, there is production of misfolded proteins, and ultimately there is neurodegeneration, which is tauopathy. So initially there is inflammation, and ultimately there is secondary neurodegeneration. So typical disease course is progressive. In more than 2/3 of the cases, it's progressive course. Generally, it starts with sleep disturbances, subtle cognitive and behavioral changes, and ultimately motor signs, movement disorders, dysautonomia, and various other features. But in 25% of the patients, it's a subacute presentation, and rarely it can be acute as well. So mostly it is chronic progressive course. Now, clinical features, there are many clinical features. We can broadly divide clinical features into 5 subgroups, and these 5 neurological profiles are sleep disorder, bulbar dysfunction, movement disorders, cognitive impairment, neuromuscular manifestation, and generally these are combination of all these symptoms. So truly isolated clinical manifestations are very, very rare. Only few percent, less than 2% in most of the studies. So it's a combination of signs and symptoms which can lead us to the probable diagnosis of Eglon-5. It can mimic several neurodegenerative disorders and other autoimmune disorders. And it's a great mimicker in neurology. So now in the modern times, I think the most important and the great mimicker is Eglon-5. You can comfortably say that Eglon-5 is everything. So once a patient comes to you, it's basically history and physical examination, and you try to pick up bits and pieces. And if you gather together, Eglon-5 is a great mimicker of other neurodegenerative disorders and autoimmune disorders. And in most of the series, Eglon-5 antibodies are the third commonest antibodies after NAMDA and LGI1 antibodies. So it's important. So this means that we are missing lots of patients. So main reason from this review article, main reason for that prompted patients to seek medical attention was bulbar syndrome, gait disorder, movement disorder, sleep disorder, cognitive impairment, neuromuscular symptoms, and oculomotor symptoms. So it almost covers all of neurology. So cognitive impairment is present in, ultimately present in 50% of the patient, and 18% of the patient, they fulfill criteria of dementia. Some have confusional episodes, anxiety, depression, apathy, delusions, hallucinations, and encephalopathy-like picture. But these cognitive deficits, they have not been studied in detail. So they do not show a distinctive clinical profile. Preliminary studies, the pattern of CSF biomarkers are not compatible with Alzheimer's disease or any other dementia. So it's a separate disease. Now, movement disorders, they constitute a very important part of Eglon-5 disease. Sleep disorders, they are present in more than 80% of the cases. The movement disorders, they are also present in more than 2/3 of the patients, almost 73% of the patients in one series. And patients can have postural instability and frequent falls, cerebral ataxia, stiffness, bradykinesia, coriform movements, craniofacial dyskinesis, abnormal body postures, myoclonus, or myarrhythmia. So you can have whole sort of movement disorders. Now, coming to movement disorders, because at times movement disorders can be the main or presenting symptom of these diseases, and ultimately it's almost in 57% of the patient, it's the main disorder for which the patients, they come to the clinics. So movement disorders may precede sleep manifestations and may be the reason for initial consultation. And out of this, this article from where I've taken this data, the frequency of different clinical phenotypes in 72 patients with anti-Eglon-5 disease, you can see that 37% were of movement disorder. So movement disorder can be a very, very prominent feature, and movement disorder can mimic stiff person syndrome, Parkinsonism, Huntington's disease, cerebral ataxia, and facial and abdominal dyskinesis. Now, these movement disorders, they don't come in isolation. There is a combination of different movement disorders that can constitute gait and balance disorder, coriform movements. These can be focal or generalized. You can have bradykinesia, which can be unilateral, or just like Parkinson's disease, or bilateral, or rest tremors, hypophonia, dystonia. Dystonia can be of many types. You can have abnormal body postures and limb rigidity, and you can have other hyperkinetic movement disorders like facial dyskinesias, myoclonus, akathisia, and abdominal dyskinesias. So if you see the diagram in the slide, movement disorders, they are in combination with one movement disorder is in combination with many other movement disorders. So it's a combination of movement disorders which you have to specify in that particular patient. So sleep disorder is a very, very important component. Almost 84% of the patients, NREM and REM parasomnias, vocalization, sleep disorder breathing, choking episodes, insomnia, central hypoventilation. So there are many sleep disorders, and these sleep disorders, they can be present in many other disorders, but there are differences between sleep disorder of Eglon 5 and other disorders. Now, bulbar dysfunction is a very prominent feature, and more than almost 2/3 of the patients. You can have dysarthria, dysphagia, stridor, vocal cord paralysis. Vocal cord paralysis can be unilateral or bilateral. You can have central hypoventilation. You can have tongue atrophy and fasciculations. So it's a very important feature, tongue atrophy and fasciculation, because tongue atrophy and fasciculation is present in motor neuron disease as well, and in anti-musk myasthenia and many other disorders. So you have to look for Eglon 5 once you have tongue atrophy and fasciculations, and you can have laryngeal spasms as well. So Eglon 5 autoimmunity, it can mimic classical ALS, but the combination of other features that would help differentiating from amyotrophic lateral sclerosis. So there have been many case reports, Eglon 5 presenting as ALS-like phenotype. And these phenotypes, they are generally not very good responder to treatment. Now, ocular involvement, it has been described, and there are many types of ocular involvement. You can have various gaze palsies like horizontal, vertical, or all supranuclear, and mostly it is supranuclear gaze palsy. So initially, the description was PSP-like syndrome. So, but the difference between PSP and Eglon 5 is, in PSP, you have more of prominent downward gaze palsy. But in Eglon 5, it is different. It's upward more rather than downward. You can have slow static velocities, impaired soon pursuit. You can have different types of nystagmus. And in 23% of the patients, you can have ptosis. So it can mimic, if you have bulbar dysfunction and ptosis, it can closely mimic myasthenia gravis as well, and that anti-musk phenotype. And in few patients, you can have optic neuropathy with papillitis as well. So gait disorder I've already talked about. It's one of the most commonest movement disorder. You can have frequent falls. And neuromuscular manifestations, there are many. These can be fasciculations, muscle weakness and atrophy, cramps and stiffness, peripheral nerve hyperexcitability, spasticity, hyperreflexia, rigidity, hyperexplexia. It's almost present in 1/3 of the patients, and it can be a predominant manifestation in 8% of the cases. And autonomic dysfunction, it's there in Eglon 5, but it's different from multiple system atrophy. Now, in MSA, the autonomic dysfunction is very, very severe component. And in Eglon 5, it is usually mild, not that severe as compared to MSA. And you can have dysphagia, gastroparesis, constipation, and episodic hyperventilation, dyshydrosis, vocal cord paralysis, and sleep disorder. These are all autonomic dysfunction. Now, other phenotypes. The other phenotypes, they're fast coming up. You see case reports every other day. You see case reports defining different phenotypes of Eglon 5, like facial lingual palatal myarrhythmia, orthostatic myoclonus, tick-like movements, bilateral vestibulopathy, facial paralysis, tongue neuralgia, trigeminal neuralgia, cold intolerance, epilepsy. Epilepsy is present in 5% of the cases. Cardiomyopathy, Takotsubo, cardiomyopathy, sudden cardiac death, pop music, hallucinations, and there are many other hallucinations as well. Acute onset with meningeal enhancement, and there are many other phenotypes we are coming across every day. So it has associations. At times, initial presentation can be just like influenza-like illnesses. And now you know NAMDAR encephalitis, Neuraxin 3 encephalitis, and this Eglon 5, they can all have initial influenza-like illnesses like presentation. And there is association with Epstein-Barr virus and herpes viruses. It has association with other autoimmune diseases in less than 10% of the cases, like vitiligo, Hashimoto's, and cognitive disorders in few. And there has been coexistence with other antibodies which have been reported, like LJ1, GAD65, GABA-B. Now you have to then look at the predominant disorder if you have all these antibodies positive. Now, Langerhans histiocytosis and plus Eglon-5 antibodies have been reported in 2 years old. So this is the youngest patient which has been reported in the literature so far. Generally, it's a disease of the 50 plus people. Now, the key features in differential diagnosis. The most important feature in differential diagnosis is combination of signs and symptoms. So there is no need to test for anti-Eglon-5 antibodies in a patient with well-established diagnosis of a neurodegenerative disorder. So if you have a patient who has classical ALS, there is no need of testing Eglon-5. But if you have a patient of ALS and he has prominent sleep disorder and there are other features which you can really put in one place, then always think of Eglon-5. So it is a combination of signs and symptoms that would define Eglon-5. So it can mimic myasthenia gravis, but in myasthenia gravis, you don't expect sleep disorder or other movement disorders. It can mimic PSP, progressive supranuclear palsy. It can mimic multiple system atrophy, Whipple disease. Now the difference would be you can have orofacial dyskinesis in Eglon-5, but in Whipple disease, you have typical convergence, divergence, and nystagmus, which you will not find in Eglon-5. So there are features, if you look closely and if you look in detail, then there are features which can really differentiate from one disorder from another disorder. So it's a very, very important differential diagnosis of all our important neurodegenerative disorders and our autoimmune disorders like autoimmune encephalitis and other disorders. So PSP, I've already talked about. It's the downward gaze, which is very important in PSP, but not in Eglon-5. Other features, they can closely resemble PSP, and initially the diagnosis may be PSP, but ultimately you will have features which are not in keeping with PSP. Now, this is important to differentiate as well, because Eglon-5, you can offer treatment in the beginning, but in PSP, you don't have any treatment. It's just a supportive care. So this article is from 2024, and you can see Eglon-5 presenting as and coming in differential diagnosis of so many disorders like PSP, Whipple's, stiff person, Huntington's, cognitive subtypes as a differential diagnosis of other dementias, bulbar subtype, myasthenia, motor neuron disease, stiff person syndrome, Morvan syndrome, and sleep disorder. But the sleep disorder of Eglon-5 would be different from, there will be multiple differences between the sleep disorder of Eglon-5 and other autoimmune or neurodegenerative disorders. And this we can specify, we do video sleep studies, polysomnography. Now MRI is normal in 86% of the cases. So MRI usually shows atrophy. So it's mostly, in almost 90% of the cases, MRI is normal. So it's abnormal in 10 to 14% of the cases. So there have been various case reports of MRI changes. I have selected few. You can see diffusion restriction in brainstem and the occipital horn. Then there is another patient with dural enhancement and subcortical lesions which resolved after treatment. So there is importance of treatment as well. Another with prominent temporal lobe atrophy and high convexity tight sulci, which is a feature of generally NPH. So this can be a feature of this Eglon-5 disease as well. So another patient with brainstem changes which resolved after treatment. So cortex swelling, these findings, if you see, the similar findings, Professor Ali Yusuf already delineated in orexin 3 alpha, and these cortical swelling, these are present in MOGAD, these are present in even lambda encephalitis. So these this cortical swelling, this has been reported in, which we call as cerebral cortical encephalitis. This has been reported in Eglon-5 as well. And pial meningeal enhancement. So you can have PL enhancement, and you can have dural enhancement as well. So another patient, you can see subcortical lesions. These are very similar to other encephalitides, which Dr. Ali has already presented. So you can have vasogenic edema and patchy contrast enhancement. Now, trigeminal nerve involvement. In autoimmune diseases, once we see trigeminal involvement, we are always thinking of neuroshogun, multiple sclerosis, and Aglon 5 is another. But the trigeminal neuralgia of Aglon 5 is different from other disorders. It's not typical neuralgia, it's more of a constant burning pain. Now, PET scan. PET scan, it has been reported to be abnormal in 50% of the patients with Aglon 5 disease. Now, this is a case series from 7 patients. They have been described by from our neighboring country. And you can see basal ganglia hypermetabolism and brainstem hypermetabolism on PET scan. So, PET scan can be another tool in reaching the diagnosis. And there is hypometabolism of occipital lobes. Now, lab testing, CSF is usually normal. Pleocytosis, which is usually mild, is present in only 1/3 of the patients. Protein is elevated in 41, only mildly raised protein, and 41% of the patients. OCBs, these are present in only 15%. So CSF is usually normal. Now, Aglon 5 antibodies, they are detected by cell-based assays, and they can be confirmed by immunohistochemistry in the rat brain. And these are present in 95 to 100% of the patients. Now, 10% of the patients who will have CSF negative, who will be CSF negative, but serum positive only. And serum antibody titers, they correlate with disease activity and the immunotherapy. Now, IgG4 is the most predominant antibody, as I've already discussed, but IgG1 is always present. So there is a strong association with HLA-DRB 1001 and HLA-DQB1 501. It has almost 60% prevalence in Aglon 5 versus 2% in normal population. Now, Aglon 5 composite disease composite score has been presented for diagnosing these patients, for disease monitoring of these patients, and for assessing the disease severity of these patients. So it encompasses bulbar, sleep, movement disorders, cognition, and other disorders. Now you see the highest score has been attributed to stridor and basically related to the sleep disorders, because these sleep disorders, these carry high mortality and morbidity. Now, treatment overview. Now, this is predominantly a IgG4 disease, but there is IgG1 component as well. So these, in the first line therapy, steroids and IVIG. So there is a response of only for 55 to 55.8% in most of the series. So this response is because there is IgG1 present and there is a complement element, so they respond, but not every patient. But it's predominantly a IgG4 disease. So the best drug would be obviously rituximab. So second line therapies, they have a 63% response rate, and the overall response rate is 75%. So immunotherapy is very, very effective if we start in the early phase. In the neurodegenerative phase, then the immunotherapy doesn't work very well. So, and there are few phenotypes in which immunotherapy really works well. With the better outcomes have been reported with cognitive impairment and with atypical phenotypes rather than with typical sleep and bulbar disorders. Now, sleep and bulbar disorders, there are negative prognostic markers. So in general, immunotherapy seems to be very effective than was previously thought, almost in 2/3 of patients, if we diagnose them within the first year of their disease illness. Now, it is a multidisciplinary team approach, especially in these patients, because you have to cater for sleep disorders and many other disorders. Now, prognosis is generally poor. Better outcomes are with earlier diagnosis, prompt immunotherapy, less advanced neurodegeneration at presentation. And mortality rate are higher than other autoimmune encephalitis. And major cause of death are basically respiratory, like laryngospasm, respiratory failure, central hypoventilation, aspiration pneumonias, and cardiac events. Now, in the last 10 years, there has been a lot of progress made in understanding of Aglon 5 disease. This is from the review article. And what we know, and there are many unknowns. There are few knowns and there are many unknowns. Few knowns are disease onset mainly after 50 years of age. It's progressive course in 2/3 of the patients. It's a combination of many clinical syndromes I've already discussed. Abnormal movements are very common, and in more than almost 57% of the patients, these can be the presenting feature or the main predominant feature. Characteristic sleep disorder in more than 85 or 84% of the patients. It's strong HLA association and tauopathy, which is different from traditional tauopathies, and we know the antigen Eglon-5, which is a cell membrane based antigen. We know the antigen, but its function we still don't know. And immunotherapy in acute and subacute phase is very effective. Now, the unknowns are we still don't know most of the triggers. We still don't know the predisposing factors. Prevalence and incidence is just estimated. We still don't know the natural history. We are still not very clear about the frequency of motor neuron involvement. The motor neuron involvement, I tell you, it's anterior horn cell, and it can be motor axon as well. So in matter of motor axonopathies and anterior horn cells, motor axonopathies, they are also present in Sjogren disease as well. So you have to, it's an anterior horn cell plus motor axons. So we still don't know the significance of hippocampal tau deposits. We still don't know the clear function of Eglon-5, and we still don't know the relationship of Eglon-5 with the innate immunity, and whether we should treat all patients with immunotherapy or not, and what's the best treatment so far, and the response of different symptoms is still, it's an ongoing process. So in conclusion, Eglon-5 disease is characterized by a heterogeneous spectrum of clinical symptoms and a great mimicker of other autoimmune and neurodegenerative diseases. It's important to diagnose early as treatment responsiveness is in the early phase. Thank you. Questions? When the testing will be available? Sir, Tahir is aware. Sir, basically, point to pick up this lecture was press upon Sir Tahir to start this test as early as possible.
We have already conducted the induction phase trials, and this test will be available from Monday. The 10 days test is recommended.
Inshallah.
We also have the service for HNADR and so both kinds of tests are available. In addition, if interested in muscle problems, we also we have inducted the antibodies to test for antibodies to
reductors and
second related mark. So for this, it's long 5 from Monday. It's a serum test.
सर इसमें देख रहे हैं 10% पेशेंट्स तो जो है ना को सीरम में पॉजिटिव होंगे और उसमें नहीं होंगे सीएसएफ में नहीं होंगे तो इवन सीएसएफ सीरम इज गुड फॉर अस और सर केएफ जो कैपा फ्री लाइट चेन है आर यू स्टार्टिंग इट और नॉट in CSF
validation that we know what is taking
So
I have to read what kind of reference to there, what kind of findings we are expecting.
So we can send you those patients who are CSF possibilities positive. We can send those patients to you. You can validate those, and we can start off with this because as he was saying that. Previous speaker was saying that this is a relatively cheaper test, more quantitative, more easy to do.
We are already
yes, we. Inshallah. Inshallah.
Wasim, I have a comment and a question, The comment is, do you think that this disease is everywhere? We have to wait till 50 years of age?
Sir, one of the patients I discussed, he had Langerhans cell histiocytosis, and he was 2 years of age. So I think these are just preliminary studies, and in our population, they may be a younger population, because we are seeing patients in their 40s and 30s who have tongue atrophy, movement disorder, neurocognitive issues, and they are not fitting into one. Maybe we start testing and then we are more confident that whatever we are saying, it is right. Because here now there's even if I say that it's a glon 5 disease, you can say you see a patient with a combination of signs and symptoms. You say this is probably glon 5, but you have to confirm it. Otherwise, nobody's going to believe it. So I think in our population, it may be different. Now, still, at the moment, it's more common above 50 years of the, and maybe because we are diagnosing late. Sure. So I think again, sir, history, and history. Yeah. रात को सोते में डिस्टर्ब तो नहीं होते, शोर तो नहीं चलता है.
Knowing these studies, that makes the life of neurologists more difficult. Yeah, but I have a question. What typical sleep disorder is sleep?
Sir, ma'am, in glon 5 disease, you will have combination of all sleep disorders. So you have rapid eye REM sleep disorder, you have NREM, parasomnias, and by the end of the night, sleep starts becoming normal. So if you do polysomnogram, by the end of the night, it starts becoming normal, which doesn't happen in Morvan syndrome. Okay. Because in Morvan syndrome, they remain in the severe insomnia. Severe insomnia is also a feature of neurexin 3 alpha. So and DPPX. So we have to differentiate from all these disorders. Now here you will have sleep disorder breathing. Now I have one serving soldier with me at the moment who has had who will initially present to us with acute vasculopathy, and then he had some brainstem signs. But MRI was normal. CSF there was slightly raised protein. He was not responding to steroids, so we did plasma exchange. He became very well, and he went home. And and he's almost 45 years of age, and he came to us a year later, and this time he has typical tongue atrophy, and he has sleep disorder breathing and sleep vocalizations as well, and severe OSA. So he's obese as well. So it's difficult to differentiate whether it's primarily OSA or something different. But if you see the combination of signs, he had vestibulopathy, he had cognitive issues, now he has severe bulbar dysfunction and tongue atrophy and sleep vocalizations. And so you can make a good guess. So we did plasma exchange again. He has responded. He is now taking orally, and now we have planned for rituximab injection. Sir, just another point, CAR T cell therapy would be available with FBMTC, I think within next few months. They're already on it. One of the component I think they are importing. The moment it comes, I think it's a gap of 5 million. I've checked from them 5 million, 50 lakh. तो ये ऑटो आप देखना वन ऑफ थेरेपी है सर, अगर हम दें ना सेल सेट भी दें महीने की तो 40-50 हज़ार रुपये खर्चा आ जाता है. तो उस लिहाज से देखिए अगर 5 साल तो आपने देनी है हार्ट डिजीज में, कुछ में लाइफ लॉन्ग देनी है. तो मॉडरेट टू सीवियर डिजीज में आई थिंक CAR TCL therapy would be a good choice as compared to auto BMT. कि auto BMT से वैसे नाम सुन के लोग घबरा जाते हैं बहुत ज़्यादा. Although हमारे जितने पेशेंट हमने कराए recently auto BMT, they are doing very well, sir. हाँ बिल्कुल सर. T cells हाँ सर. T cells हाँ. सर वो लिखा सर इन द लास्ट लेक्चर वो उन्होंने कहा ना कि जो आइकन्स थे ना इम्यून सेल एसोसिएटेड जो न्यूरोटॉक्सिसिटी सिंड्रोम से, वो उन लोगों में ज़्यादा था जिनका बी सेल लोड ज़्यादा था. तो हमारे जो पेशेंट्स होंगे सर, इनका तो बी सेल लोड इतना ज़्यादा नहीं होगा ना. अब हमारे पास पेशेंट्स हैं, न्यूरो शॉगरन के पेशेंट्स हैं, सीवियरली अटैक्सिक और सीरो पॉजिटिविटी भी है. शॉगरन का गेन है कि 50% सीरो पॉजिटिव होते हैं, 50% सीरो नेगेटिव होते हैं. दे आर नॉट रिस्पॉन्डिंग टू इवन एक पेशेंट को हमने अभी डार्जल एक्स भी दी है सर, NDCD38, एंड पार्शल सा रिस्पॉन्स है. बस इतना रिस्पॉन्स हो गया, कोई स्पीच बेहतर हो गई है, टैक्सिया बेहतर हो गया, थोड़े से वो बेहतर हो गए हैं, लेकिन बहुत अच्छा रिस्पॉन्स नहीं आया. नाउ वी हैव ये पेशेंट्स हैं जिनको आई थिंक क्योंकि अल्टीमेटली आपको पता सर ये बी सेल डिसऑर्डर अगर हम नहीं ट्रीट करेंगे, अल्टीमेटली इट विल गेट कन्वर्टेड टू बी सेल लिम्फोमा. So the neurological side effects, they were more in patients, those who had more B cell. So this is a problem with hematology, not with us. In neurology, most of the patients which we will be managing, B cell itna load nahi hoga hamare paas, sir.
Thank you very much. So we end this session. So the work of neurologists has become more difficult. So you cannot take for granted patient suffering from insomnia. You just give him medication. Patient coming to you with cognitive impairment, you just cannot say that he's just aging and that's senility. So you have seen so many good things about this session. You have learned how to see the MRI more seriously, how to do the CSF biomarker study, which will help you in managing demyelinating disease. And Dr. Wasim Wali has give us a fear that something new is coming up. So you have to study your neurology more. And this disease is, I think, everywhere. Let's hope that we get a good solution for that. We'll hearing from Wasim Wali again then. Thank you very much. We end this section.
So that's the end of session 2. I would request Professor Naila Shehbaz, Professor Emerita, Civil Hospital Karachi, and President Pakistan Society of Neurology for the certificate distribution. Professor Ali Yusuf. Professor Wasim Wali. Professor Mazhar. Professor Mazhar Badsha. Sir.
I'm sorry. Thank you.
Dr. Mansoor Iqbal. Dr. Riaz Mahmood. Thank you very much, ma'am. So now we'll move on to the next session. That is the third session without wasting any time. And for the third session, we have chairs Professor Tahir Aziz, Head of Immunology Department at Shifa International Hospital, and Professor Memuna Siddiqui, who is the Professor of Neurology and Dean of Shifa Tamir Millet University. And the co-chairs are Dr. Aisha Astam, Assistant Professor of Neurology, Mayo Hospital, Lahore, King Edward Medical University, and Dr. Meher Bano, Consultant Neurologist and Head of Department, KRL Hospital, Islamabad. Should we start, sir? Yes. So the first presentation is by Dr. Haris Majid, Assistant Professor at Pakistan Institute of Medical Sciences, Islamabad. And the topic is PATKRIMS report.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. So I have no disclosures regarding financial or any other conflict of interest. So what is CTRIMS? The acronym basically stands for the Committee for Treatment and Research in MS, and now it extends to MS and other demyelinating disorders. And this year, other autoimmune and neuroimmunology disorders have also been included in TRIMS programs. So it provides a platform for clinical and translational research in MS and associated disorders, updates on DMTs, disease-modifying therapies, and clinical practice, and multinational research collaborations. So these are the major TRIMS networks across the world. The first and oldest one is the PATKRIMS, which is European Committee for Treatment and Research in MS, which was established in 1985. And then the American, which covers both South and North American region. This TRIMS was established in 1996. And then PATKRIMS, which covers the entire Asian region. And we had Professor Fujihara as President Emeritus of this PATKRIMS. And this was established in 2008. And MINAC-TRIMS is for the MENA region. And then we have also national TRIMS, including Sri Lankan TRIMS, which was established in 2019, and our own Paktrims, which was operational since 2021. So this is not directly related to the TRIMS report, but I would just like to mention here that Professor Mazhar Bacha forced us to start an MS clinic, and which resulted in expanding our knowledge of MS and doing some research work with respect to this. So later on, I was instructed by Sir Wasay to write this article of MS in Pakistan and need for an MS registry. So this started off my own interest in multiple sclerosis and associated disorders. And in 2019, Sir Wasay formed a MS Research and Education Forum in Khan University, and I was made its coordinator. So under this research forum, we conducted 5 workshops in 2019 in various major cities of Pakistan. So in 2021, this research forum expanded further, and we started conducting annual conferences, mostly in Islamabad. And we have written about this in our editorial in Pakistan Journal of Medical Association in 2023. So the first conference was conducted in Karachi as a virtual event. The subsequent conferences have mostly been held in Islamabad, except for one which was held in 2023. And the organizing committee basically is headed by Sir Wasay, then myself, Dr. Hassan, Dr. Wali, then the arrangements are managed by Mr. Nayab. And this is only possible with the involvement and help of local neurology institutes, especially in 2023, where the LRH, HMC, and KTH institutes gathered together, and they hosted the entire event. And even now, PIMS and Shifa and Fauji Foundation and Polyclinic Hospital all are actively involved in managing and organizing this event. So the conference highlights for us include new insights and research and engagement with national and international MS experts. Especially, I would like to mention Dr. Burhan Chaudhry, who's been a regular speaker in all of the conferences. Then we've had speakers from Turkey, Professor Matthew from India. We've had speakers from Saudi Arabia, along with national speakers, Professor Wasim Ali and Ali Yusuf, who have been regular participants. Then Professor Wasay, myself, Dr. Ahmad Wali, he's also been presenting at all of the events, and Dr. Hassan and Dr. Waleed are also regular presenters. So amongst the other highlights, it is basically a forum for community collaboration in the form of industry presentations. And a very interesting aspect was patient's perspective presentation session. And this was in which we invited 2 patients. This was in 2021, who shared their MS journey. And also we have been engaged in involving the support programs, including Battlemal and other supporting funds. For myself, the major highlight is the regional data presentations. And this is just a bar chart of showing how the data presentations have evolved over the last 4 years. And this is the number of patients presented each year. So it's a total of 1308 patients whose data has been presented. Most of the data is that is 480 is from Islamabad and Pindi region. The rest is almost equally divided between Sindh, Punjab, and KPK. And there have been 63 patients' data shared by Dr. Ahmad Wali, primarily from Balochistan. And this is the total number of centers which have contributed to their data presentation so far. So it's a total of 21 centers till date. The 5th conference data has not been included in this slide. So just to give you a flavor of what the breakup of the 1308 patients data is, So it's 60% MS patients, which is 785, 21% is NMO, and 4%, which is 55 number, is of MOGAD. And others, which includes clinically isolated syndromes amongst other disorders, is 15%. So the associate publication, our major and perhaps only publication, is the MS Care in Pakistan report, which was published in PGNS in 2022. And this encompassed the entire data, which was presented at the first conference. Then another associated publication is this was a collaborative work between PIMS and AKU, in which data of 188 patients was presented, and it was published in International Journal of MS Care. Then there was an article amongst the citations. There was an article by Dr. Sara Razak, who is a rehab physician, and this also cited Paktrims efforts. And then Professor Wasim Yamut, who is the president of PATKRIMS, he mentioned and cited Paktrims in his editorial on disease-modifying therapies entering the WHO essential medication list. And we have documented our journey of Paktrims and MS Research and Education Forum in the article that I've mentioned earlier as well, and in our editorial. So this is my last slide, and this is regarding future direction. So some of it has already been discussed by Wasay Saab in the morning session. So we do plan to collaborate now further with other specialties, especially ophthalmology, rehab medicine, radiology, and now having seen the interest, immunology as well, especially with Professor Tahira Aziz as our participant today. Then we are planning to start work on preparing guidelines, because most of the regional ACTRIMS are working on their own developing indigenous guidelines according to the availability of local drugs. And we plan on publishing the presented data. And also we plan to start collaborating with international TRIMS, and some of that collaboration has already started today, as we have had 2 presidents of TRIMS invited today. So this was my last slide, and I would like to invite suggestions and ideas on how to expand on further with regards to further development. And we have achieved actually a horizontal growth, and now we want to intensify our progress as well. So I would like to invite comments from our worthy participants. Professor Aslan, if you can share your ideas how we can build on this further, and then Professor Naila as well, and others.
Why don't we have Professor Naila first?
Right, sir. Yes.
We are to announce MS registry in this program and this evening, and we will explain the whole procedure of how that registry go on. And I think because better guidelines are made when you have some data on your on the disease scores and the disease appearances in your community, that it would be better if we start guidelines after we collect some data. Because most of the people, in fact, I was talking to someone, I think Dr. Waleed Khan was here in our updates conference this year, and she was suggesting that Movement Disorder Society and all those societies, they should develop guidelines after you have made the registry. So I think that is better option, that if we start guidelines after we have some data from our community. So that is, I think, and I think we will, when we have announced the registry, I would request all our neurologists in Pakistan to participate in this registry, and we will make focal person or someone उस registry में जितना participate करेंगे उतना हमें अपने मुल्क में disease prevalence के बारे में पता चलेगा. Details will be shortly here. Data के बारे में सब कुछ reservations, and we will describe all those reservations.
Right.
So,
thank you. You have 200 patients with MS and 200 patients with other disease. It's going to make a full bias from there.
Exactly.
and you have PATKRIMS available, and you have it on better knowledge, तो वो फिर पेशेंट ट्रिकल करके वही करा जाते हैं दूसरी बात
Exactly.
ये है इन्हें तो हमें भेजिए और आपका वो पेशेंट भी होंगे 20 साल पहले डायग्नोज हुए
Yes.
भी होंगे 10 साल पहले डायग्नोज हुए लेकिन ये वाली डिजीज मॉगर वो वगैरह तो
Newer entrants.
आई थिंक तो होता है तो मैं 10 साल
2018 में सर.
even 10 तो इन्हें ये मॉग बता रहे हैं ये रिसेंट
Yes.
you cannot compare those numbers.
Exactly.
What we can do is perhaps see it in a prospective observational study, see क्या pattern आ रहे हैं और हमारे पास वही patient आते हैं जो affluent patient है हमारे पास दूसरा patient आपके पास आता है दूसरा patient आता है लेकिन major testing तो सारी डॉक्टर ताहिर की लैब में होती है
जी.
तो वहाँ से हमारे पास एक स्लाइड है कि डॉक्टर ताहिर के सबसे ज्यादा 4 पॉजिटिविटी उसमें भी रेफरल बायस हो सकता है कि वो के लोग ज्यादा वो टेस्ट कराने हैं माउंट तो ये भी है कि अगर हमारे पास एक ही पैनल होता है जिसमें सारे टेस्ट एक ही पैनल टेस्ट एक ब्रॉडर पैनल बनाने में इतने सारे और कॉस्ट कम होती
useful suggestion, but it would make the tests expensive. और अगर आप patient specific request बाकी रखें तो उसमें थोड़ी सी cost rationalization हो जाएगी वरना तो बड़ा सारा panel expensive भी होगा.
Exactly.
Testing gets cheaper and cheaper, and as the testing gets more available, you will come across patients having multiple positivity points.
Yes.
फिर आप परेशान हो गए ऐसे इसके साथ ये इसके साथ वो भी है ये kind of evolving. तो जिस तरह डॉक्टर नायला ने कहा कि अगर तो नेशनल रजिस्ट्री अगर लीडरशिप नेशनल बॉडी बनी तो उसमें लोगों को पता हो उनका डेटा भी सिक्योर है उसमें कोई रिजर्वेशन वगैरह लोग बनी then we get probably more realistic real data on which we will develop. अभी भी ग्रास रूट का डेटा अभी भी नहीं जैसे लोग छोटे अभी तो छोटे शहरों में जाके निवास गुजारना शुरू है गाँवों में तो नहीं तो डिजीज इज प्रॉब्ली अंडर its weak number.
Thank you. Thank you so much.
Just a brief comment. We have recently completed our study about Echoporin 4 positive patients. We preserved those sera and tested them for the presence of anti-nuclear antibodies, just to see any other disease or autoimmune. And there were findings, and then we followed these patients for 5 years and just looked into how many developed the clinical disease. So that's very interesting.
Thank you very much, Sir Haris. For the next presentation, I would like to call Dr. Muhammad Hassan Shafqat, who is working as a consultant neurologist in Gujranwala. And the topic of his presentation is NMOSD in Pakistan.
Bismillahirrahmanirrahim. I'm Dr. Muhammad Hassan Shafqat. I'm presenting NMO in Pakistan. It's a kind of review article. We just pile up everything that is about NMO in Pakistan. So NMO, the global annual incidence rate of NMO ranging from 0.4 per 100,000 population. And in US, it is about 1 to 2% prevalence. So NMO की prevalence latitude के साथ increase करती है, decrease करती है, जबकि MS की prevalence latitude के साथ decrease करती है. Regional data नहीं है, बिल्कुल भी नहीं है. पाकिस्तान, साउथ एशिया में इंडिया, पाकिस्तान, बांग्लादेश, श्रीलंका, नेपाल, मालदीव्स, भूटान, किसी भी जगह पे जितनी भी स्टडी पब्लिश हुई हैं वो ज़्यादातर केस रिपोर्ट्स हैं. एक आधी ऑब्जर्वेशनल स्टडी है, इसके अलावा ना तो रिव्यू आर्टिकल्स हैं, ना मेटा एनालिसिस हैं, ना सिस्टेमिक रिव्यूज हैं, कुछ भी नहीं है। जो एस्टिमेशन इंडिया में 3 स्टडीज हैं और उसकी टोटल जो प्रिवलेंस एस्टिमेशन है वो 0.3 to 4% पर 100,000 पॉपुलेशन है। और पाकिस्तान में आज की डेट तक कोई भी स्टडी ऐसी नहीं है जो प्रिवलेंस बेस्ड स्टडी हो। पिछले साल भी सेम टॉपिक था मेरा, 4 ही आर्टिकल थे, इस साल भी वही 4 आर्टिकल है। पिछले साल से लेके इस साल, ये पूरे 1 साल के अंदर पाकिस्तान से एनएमओ पे कोई पेपर पब्लिश नहीं हुआ। एक ही पेपर पब्लिश हुआ है जो कि इंटरनेशनल है, वो ये वाला। ये डॉक्टर हारिस का आर्टिकल है। इसके अलावा एक लाहौर से डॉक्टर सफिया बानो का पेपर है, ये काफ़ी 2020 का पेपर है। इसके अलावा ये आर्टिकल, इसमें सबसे ज़्यादा नंबर ऑफ पेशेंट्स हैं, बट इट इज़ अबाउट एक्वाफोरिन 4 पॉजिटिविटी रादर दैन, इसमें क्लिनिकल चीज़ें नहीं हैं, इसमें कोई ट्रीटमेंट गाइडलाइंस नहीं है, कोई ट्रीटमेंट डिस्कशन नहीं है। हाँ, एक्वाफोरिन 4 कितने पेशेंट का पॉजिटिव हुआ इन AFIP, वो उन्होंने इस आर्टिकल में ऐड किया, और मैंने इसको भी अपनी स्टडी में ऐड किया कि एटलीस्ट नंबर ऑफ पेशेंट्स हमें पता लग जाए कितने हैं। ये एक स्टडी MS से पब्लिश हुई थी इन 2021। ये एक स्टडी है जिसके सेकंड लार्जेस्ट नंबर ऑफ पेशेंट्स ऑफ NMO, ये हिकमत शेरानी साहब की स्टडी है। तो टोटल 11 पब्लिश रिपोर्ट्स हैं, उसमें से 6 ओरिजिनल आर्टिकल्स हैं। वो ओरिजिनल आर्टिकल्स अबाउट NMO नहीं है, टोटल 6 हैं। उसमें मैं बताता हूँ कि कैसे वो स्टेप डाउन होते हैं सारे। ओके, सबसे पहला जो पाकिस्तान से स्टडी गई थी वो इस्माइल खत्री साहब की है। इसमें इन्होंने एक्चुअली ओरिजिनल आर्टिकल अबाउट MS था, उसमें एक पेशेंट NMO का था, PGNS में पब्लिश हुई थी। जो केस रिपोर्ट्स हैं वो ज़्यादातर NMO की एसोसिएशंस हैं, NMO के साथ SLE हो गया, NMO के साथ कोई TB का पेशेंट्स हो गया, एसोसिएशंस पे केस स्टडीज हैं। पहला आर्टिकल जो सफिया बानो का, डॉक्टर सफिया बानो का आर्टिकल था, विच इज़ पब्लिश इन 2020 फ्रॉम म्यो हॉस्पिटल। उसमें टोटल 37 का कोहार्ट था, उसमें 15 पेशेंट जो हैं वो NMO के थे। फिर ये सेकंड आर्टिकल जो कि डॉक्टर हिकमत शेरानी का आर्टिकल है, इसमें टोटल कोहार्ट, डीमाइलिनेटिंग कोहार्ट जो था वो 80 पेशेंट्स का था, और उसमें से 26 पेशेंट जो थे वो NMO के थे। फिर उसके बाद 2023 में जो लेटेस्ट अप टिल डेट लेटेस्ट आर्टिकल है वो डॉक्टर हारिस का है। इसमें 36 NMO के पेशेंट्स है, और नंबर ऑफ कोहार्ट जो डीमाइलिनेटिंग कोहार्ट था वो 204 पेशेंट्स का था। एक स्टडी पब्लिश हुई थी पीडियाट्रिक पॉपुलेशन पे जो कि प्लाज्माफेरेसिस करते हैं, प्लाज्माफेरेसिस की स्टडी थी। उसमें उन्होंने 4 पेशेंट्स का NMO का प्लाज्माफेरेसिस किया था, मैंने उसे भी ऐड किया। और ये आर्टिकल जो एक्वाफोरिन 4 पॉजिटिविटी के बारे में था, इसमें कोहार्ट बहुत बड़ा है, 369 पेशेंट्स का कोहार्ट है। उसमें से 9 पेशेंट सिर्फ उन्हें एक्वाफोरिन 4 AFIP में पॉजिटिविटी के उन्होंने इस अपने कोहार्ट में शामिल किए हैं। 2024 में वही जो मैंने पहले बात की थी कि पेपर कोई पब्लिश नहीं हुआ, ये एक पेपर पब्लिश हुआ है, ये भी प्लाज्माफेरेसिस में है, KTH का डाटा है। और इसमें प्लाज्माफेरेसिस में उन्होंने 9 पेशेंट लेबल किए हैं NMOSD के, उनका उन्होंने प्लाज्माफेरेसिस किया था। 11 LETM के हैं, उनकी पॉजिटिविटी के बारे में उन्होंने कमेंट नहीं किया उस पूरे पेपर में। ये पिछले 1 साल में अगर कोई NMO के 20 पेशेंट हमें मिले हैं तो इस पेपर से मिले हैं, जबकि ये लास्ट जो पार्कटिम्स थी उसमें सबसे बड़ा डाटा इनका था। इनके पास 67 के अराउंड पेशेंट थे जो इन्होंने डाटा प्रेजेंट किया था लास्ट पार्कटिम्स में। तो कोऑपरेटिव स्टडीज तो है ही नहीं, इंसिडेंटल भी नहीं है, सिस्टेमिक रिव्यू नहीं है, ज़्यादातर ट्रीटमेंट सबने ही स्टेरॉइड दी हुई है। डिजीज मॉडिफाइंग थेरेपी सिर्फ एक ही डिटेल में है, वो डॉक्टर हारिस की स्टडी में। ज़्यादातर जो ड्रग्स यूज़ की गई हैं वो रिटुक्सीमैब हैं, एजाथैप्रिन है, मंथली स्टेरॉइड पैटर्न है, प्लाज्माफेरेसिस IVIGs हैं। IVIGs जितनी भी स्टडीज़ में मेंशन किया इन पाकिस्तान, वो सारी की सारी पीडियाट्रिक पॉपुलेशन में है, और सारी की सारी केस रिपोर्ट्स हैं। वो तो ये बात तो पहले कर ली कि ना सिस्टेमिक डाटा है, ना हमारे पास किसी भी स्टडी में, सॉरी डॉक्टर हारिस की स्टडी में NMO के अंदर डिसेबिलिटी असेसमेंट स्कोर है ही नहीं, मेंशन ही नहीं किया हुआ। मोर्टेलिटी डाटा है ही नहीं किसी भी स्टडी के अंदर। सिलेक्शन बायस बहुत ज़्यादा है, स्पेशली जो 4 पेपर पब्लिश हुए हैं उनके अंदर। और हमारा डाटा वेस्टर्न डाटा से टोटली अनऑर्गेनाइज्ड डाटा है, किसी भी तरह से वो फिट नहीं बैठता। आप किसी पेपर को खोलें, उस पेपर के अंदर हजारों डेफिशिएंसीज हैं इन डाटा, नॉट इन राइटिंग फॉर्म, इन डाटा। डाटा के अंदर सिलेक्शन बायस बहुत ज़्यादा है। सो एनएमओ है तो अनकॉमन नहीं, देखते तो बहुत हैं, लेकिन डाटा की बेस पे जो इंटरनेशनल हम भेजते हैं वो बहुत कम है, वो तो है ही नहीं। पिछले 1 साल के अंदर जब मैं ये रिव्यू आर्टिकल मैंने ये लिखा हुआ भेज दिया हमने, ये रिव्यू आर्टिकल लिखा, ये रिजेक्ट भी इसलिए हुआ कि इसमें नंबर ऑफ पेशेंट्स बड़े कम है, इसमें ज़्यादा पेशेंट, नंबर ऑफ पेशेंट ऐड करने चाहिए। डॉक्टर नायला ने आगे बात की एमएस रजिस्ट्री की। मेरा ख्याल है मैडम उसको एक्सपेंड करके एमएस की जगह डीमेलिनेटिंग रजिस्ट्री होना चाहिए, ताकि नंबर ऑफ पेशेंट ज़्यादा कोहॉर्ट बढ़े। थैंक यू। बात नहीं, क्वेश्चन लेना अभी लेना। एनी क्वेश्चंस? मेरा ख्याल है कोई नहीं।
We are not out of the shock yet. नहीं तो हसन, तुमने क्यों नहीं की स्टडी अब तक? नहीं तो सिर्फ ये एक रिव्यू भेजा है ना, स्टडी करो, स्टडी। जो भी है।
थैंक यू डॉक्टर हसन। और वाकई डॉक्टर सलान की गाइडेंस में हमने ये सारी क्लिनिकल सर्विसेज, डायग्नोस्टिक सर्विसेज डेवलप की थी एट शिफा, एंड वी हैव a very large cohort, and he's always motivating us to study these different groups, especially Ecoporin 4. It's a very large group of patients. We have recently concluded a study where we have been preserving these patients' sera, and we planned a study. After approval, we carried it out to find out if there are any other coexisting autoimmune diseases in these patients who are Ecoporin 4 positive. So we found out a number of patients, and then we followed them up, and it's about 5-year follow-up, whether these patients developed any clinical problems or other significant autoantibodies in significant titers. So that I don't recall the final sort of numbers. अच्छा, yes, we have submitted those that particular study. और कहाँ हमने भेजा? डॉक्टर सलान की होती है हमें गाइडेंस, ये तो neurology, neuroimmunology, perhaps may be counted this year's publication. So, जी
कौन से डिवाइनिटी डिसऑर्डर हो सकते हैं, ऐसे तो सब हो सकते हैं, एवरीथिंग कैन बी लाइक जीबीएस क्यूसीआईडीपी, और अगर हम उसका अगर हम हैरिसन में न्यूरोलॉजिकल मैनिफेस्टेशन देखें तो कोई स्टोरी भी नहीं है, जो न्यूरोलॉजिकल मैनिफेस्टेशन वो डिसएबल नहीं, लेकिन खास तौर पे जो चीज जो कॉमनेस समझी जाती है एसएटी में प्रैक्टिस में से इम्पोर्टेंट इस ट्रांसस्पाइनाइटिस एंड प्रैक्टिस, तो पता नहीं है कि वो उधर भी एसएलई जो है वो was the basic disease or any association to the basic.
You are absolutely right. हमारे जहन में भी यही सवाल था, तो हमने उन पेशेंट्स को लिया जिनकी शुरू में एसएलई की कोई सस्पेशन नहीं थी क्लिनिकल, और Just we preserved those sera and then tested, and those patients who came out to be ANA positive, we followed them up. So no SLE in the beginning. So perhaps addressing most of your question, that perhaps in most of those patients, SLE was not the primary disease. It could very well happen. And we know that SLE, just ANA positive, DSD NA negative. So that would be 60% of the patients. So we have come up with the numbers, and some of these, both antibody positive patients have developed the clinical disease. So after the publication, we can share that data as well. Thank you.
Sir, sorry, can we proceed? We are already getting late.
For the next presentation, I would like to call Dr. Irfanullah Khattak, Assistant Professor and Lead Consultant, Division of Neurology, Khyber Teaching Hospital, Peshawar.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Irfan Khattak, and I'm Assistant Professor and Lead Consultant in the Division of Neurology, Khyber Teaching Hospital. Before discussing the demyelinating disorder data from my hospital, I would like to discuss a short case which I saw just 2-3 weeks back in my OPD. This was a case of a demyelinating disorder presenting as isolated vomiting. So the contents of this case report includes history of presenting illness, examination, investigation, diagnosis, management, and discussion. So this was a lady, 32 years old female. She presented with vomiting, and this vomiting was almost started 2 months ago, and that was acute in onset, and the vomiting increased with the passage of time. Vomiting were multiple episodes per day, non-projectile associated with food intake, containing food particles, not responding to any antiemetics. This was associated with history of on and off headache, progressive weight loss due to poor oral intake. There was slight numbness and paresthesias in the whole body, but there was no limb weakness in this patient. There was no history of urine or stool incontinence. In systemic inquiry, there was no abdominal pain, diarrhea, constipation, fever, any gait disturbance, visual symptoms, no history of previous depressive illness. And you know, when a patient presents with isolated vomiting, she or he will definitely consult a gastroenterologist, a GP, if they label them as normal, or if they give some medicine and the patient did not respond, so they will definitely go to a psychiatrist then. So this patient had many consultations with gastroenterologist, general physician, medical specialist, psychiatric consultation, and they gave them PPIs, prokinetics, SSRIs with no improvement for almost 2 months. Vitally, she was stable, temperature, she was afebrile, pulse, blood pressure and respiratory rate were normal. Her RBS was normal, and there was no evidence of any systemic infection or metabolic instability. On her general physical examination, she was conscious oriented and she was cooperative. Cranial nerves were intact. Extraocular movements were normal. Pupil were equally reactive to light and accommodation, and fundus was also, on examination, fundus was also normal. In her motor system examination, power was normal, tone was normal, and reflexes were symmetrical and normal. Usually, अगर एक patient आपके पास चल के आता है, तो usually power उनकी हम check ही नहीं करते, 5/5 होता है. There was no objective sensory loss. Patient complaining of some numbness and paresthesia, but you know, when a female patient present to OPD, usually हम उनको psychiatric label कर देते हैं, को कहते हैं कि जी मुझे दर्द है या थोड़ी सी numbness paresthesias है. So this symptom was actually ignored. There were no cerebellar or meningeal signs. So she was labeled as psychogenic vomiting, depressive symptoms, somatization disorder, or for that she consulted different doctors. Almost उनके पास तकरीबन कोई 15 के करीब prescriptions थी. जाहिर है कि young female जिसको कोई issue नहीं हो और suddenly vomiting start हो, तो definitely she will go here and there and will get consultation, but with no remedy. So she was labeled as psychogenic vomiting. These were the investigation which were available with her, almost normal. Only TLC was 13,000. Rest of the LFTs, RFTs, metabolic profile, CBC, everything was normal. Thyroid profile was done, serum calcium, magnesium, RBS. B12 was slightly raised because she was put on, many times she was put on B12. This was the CT scan which was available with her, and this was almost normal. These were the different consultation papers that were available with her. You can see this was a gastroenterology consultation. Her OGD was done. और उसमें यहाँ पे इन्होंने डोडिनापिथी लिखा हुआ है, ठीक है? तो OGD तकरीबन almost normal ही थी, और for that she was put on omeprazole, prokinetics with no remedy. Later on, she consulted medical specialist, neurosurgeon. In every consultation, she received almost a single antidepressant. Duloxetine, she was put on duloxetine, beta blockers, again fluoxetine, with no response. Again, she consulted general medical physicians, neurosurgery consultation. आपको शायद नजर नहीं आ रही, लेकिन SSRIs तकरीबन सारे प्रिस्क्रिप्शन में उनकी SSRIs थी. किसी ने सिटोलेप्राम पे डाला हुआ था, किसी ने फ्लॉक्सेटीन, किसी ने सर्टेलिन, किसी ने ड्यूलॉक्सेटीन और बीटा ब्लॉकर. इवन के ये एक कंसल्टेशन में इसको HCQ भी स्टार्ट की गई थी. आई डोंट नो, ये एक न्यूरोसर्जन की प्रिस्क्रिप्शन थी. शी वाज स्टार्टेड ऑन डिफरेंट मेडिकेशन. This was a psychiatric consultation she took, and इसमें भी इनको SSRI, एसिटोलोप्राम और ब्रोमाज़ेपाम स्टार्ट की गई थी, लेकिन इनको कोई फर्क नहीं पड़ रहा था. She remained admitted under a psychiatrist in psychiatry unit for almost 10 days, 1 week to 10 days, and she was labeled as psychogenic vomiting. शायद आप लोगों को नजर नहीं आ रही. और she was put on sertraline, clonazepam, etc. लेकिन उनको कोई फर्क नहीं पड़ा. Abdominal ultrasound was performed, which was normal. 2-3 times her NCS was also done, because थोड़ी बहुत उनको वो numbness वगैरह हो रही थी, तो न्यूरोसर्जन्स ने उनको NCS भी कराया था, जिसमें किसी ने CTS लिखा हुआ है, किसी ने क्या सेंसरी न्यूरोपैथी है, लेकिन डिफरेंट उन्होंने 2-3 उनके पास NCS की वो थी. X-ray rectal abdomen was normal, ultrasound was normal, barium swallow, OGD almost normal. किसी ने CSF भी कराया था, जिसमें mild protein raised था. I don't know which reason किसने कराया था from a different city, लेकिन ये के इन्वेस्टिगेशन में. अच्छा जी, एक पेशेंट नॉर्मली हमारे पास OPD में आता है जो खुद चल के आता है, तो हम अगर उसकी एग्जामिनेशन करते हैं तो हम ज्यादातर तो रिफ्लेक्सेस चेक करते हैं, ठीक है? यानी अगर एक पेशेंट का पावर ठीक है तो हम उन प्लांटर्स चेक ही नहीं करते ऐसे पेशेंट्स की. तो हम वी री एग्जामिन हर. जो हमने जब री एग्जामिन किया तो ओनली थिंग which come out to be positive was plantar were upgoing. So a patient having no sensory levels, having no hyperreflexia, power or 5/5, only thing that come out to be plantars were upgoing. So उसके बाद हमें फिर MRI सर्वाइकल और MRI ब्रेन करानी पड़ी उनकी. वहां पे ये फाइंडिंग आ गई. So you can see longitudinally extensive transverse myelitis with area postrema syndrome. So area postrema was the area which was involved, and उसकी वजह से उस पेशेंट को persistently दो महीने से वोमिटिंग हो रही थी. लेकिन उसके बावजूद भी पेशेंट की किसी ने MRI की नहीं थी. CT स्कैन नॉर्मली कभी कभार आपको ये चीजें नहीं दिखा सकता, तो CT स्कैन नॉर्मल था. This was the area postrema syndrome. एरिया पोस्ट्रीमा की इन्वॉल्वमेंट थी. टिपिकल आप बुक में जाएं, आप नेट पे जाएं ना, एग्जैक्टली इसी तरह की पिक्चर आपको मिलती है एरिया पोस्ट्रीमा. ये वाली है. So MRI brain and cervical spine was performed, and which showed a longitudinally extensive transverse myelitis along with area postrema syndrome, which explains the vomiting. So this was the case. Acha, we sent the NMO antibody, which came out to be positive. So she was started on, so she was labeled as area postrema syndrome with elatium and NMO spectrum disorder. And clinical features, MRI और aquaporin 4 positivity जो है उसकी तकरीबन पॉजिटिव आ गई थी. She was started on IV methylprednisolone. On day 3, her vomiting stopped. और 2 महीने से उसको वोमिटिंग स्टॉप ही नहीं हो रही थी। उसके बाद अभी उसको फर्स्ट डोज ऑफ रिटक्सिमैब भी शी रिसीव्ड, शी वाज गिवन सपोर्टिव ट्रीटमेंट और फॉलोअप के लिए बुलाया हुआ है। So NMO spectrum disorder, as we all know, is an autoimmune disease involving optic nerves, spinal cord and brainstem, और relapsing course हो सकता है। एक्वापोरिन एंटीबॉडीज आगे डिस्कस भी होगी, ऑलरेडी डिस्कस भी हो चुकी है। So this was a case which we received 2 weeks back. सो डॉक्टर हारिस ने कहा कि इसको हम प्रेजेंट कर लेते हैं। सो अगर किसी भी पेशेंट में आइसोलेटेड वोमिटिंग है और कुछ भी आपको नहीं मिल रहा, सो यू कैन गो फॉर MRI ब्रेन, और वो भी अच्छी क्वालिटी के, क्योंकि ये एरिया पोस्टिमा सिंड्रोम शायद हमें ओपन MRI पे इसकी फाइंडिंग ना मिले। Now coming to the original data that we have in Khyber Teaching Hospital, and for the last 1 year we collected this data. Almost दिसंबर में PATKRIMS होता है, तो उनके लिए हमें 1 साल के लिए पेशेंट रखने होते हैं। Inclusion criteria: diagnosed or suspected case of CNS demyelinating disease, patient presenting to neurology OPD, and adults of both genders were included in our पेशेंट डेटा। सो हमारे पास तकरीबन जो 1 साल में पेशेंट आए थे जिनको हम सस्पेक्ट कर रहे थे CNS डीमाइलिनेशन, 51 नंबर ऑफ पेशेंट और 51 कंफर्म 21 डीमाइलिनेशन थी, और इसके अलावा अदर्स 30। अदर्स थोड़े से ज्यादा हैं, उसकी भी रीजन मैं बता दूंगा आगे कि क्यों अदर्स ज्यादा हैं। अच्छा, इसमें कंफर्म हमारे पास MS के 8 पेशेंट हैं एंड क्लिनिकल आइसोलेटेड सिंड्रोम के 4 पेशेंट्स, और NMOSD की भी 8 पेशेंट हैं। NMOSD इसलिए हमारे पास ज़्यादा आ रहे हैं क्योंकि उनकी वो एंटीबॉडीज़ का वो अच्छा है, तो हम फ़ौरन भेज देते हैं, और MS का वैसी थोड़ी सी प्रेवलेंस ज़्यादा है, लेकिन NMO के हमारे पास इसलिए ज़्यादा आ रही है क्योंकि हम एंटीबॉडीज़ फ्रीक्वेंटली भेज रहे हैं। अच्छा, ये एक पेशेंट एडम का था।
Irfan, you have 2 more minutes, please.
ओके, सो MS पेशेंट्स टोटली जो 8 पेशेंट थे उनमें रिलैप्सिंग रेमिटिंग 5 थे, 2 जो है सेकेंडरी प्रोग्रेसिव थी, 1 प्राइमरी प्रोग्रेसिव था। क्लिनिकल आइसोलेटेड सिंड्रोम में 3 out of 4 वर ट्रांसवर्स माइलाइटिस एंड 1 वाज ऑप्टिक न्यूराइटिस। NMOSD के 8 पेशेंट थे जिनमें 5 सीरो पॉजिटिव थे और 3 सीरो नेगेटिव। ऑलमोस्ट 2:1, फीमेल 34 थी, 17 मेल थे, और जो NMO के 8 पेशेंट थे उनमें 6 फीमेल थी, 2 मेल थे। अदर्स में हमारे पास जो आ रहे हैं, CNS TB के 3 पेशेंट थे, 2 CNS मेट्स, CNS वेस्कुलाइटिस के 5 पेशेंट, लिम्फोमा, ऑटोइम्यून। हमें सबसे ज्यादा प्रॉब्लम ऑटोइम्यून एन्केफेलाइटिस में आ रही है, डायग्नोसिस में भी आ रही है, मैनेजमेंट में भी आ रही है, पता ही नहीं चल रहा कि, क्योंकि आपको कभी कभार MRI पे कुछ नजर नहीं आता, और जो उसका प्रोफाइल है वो थोड़ा महंगा है। एक टॉक्सोप्लाज्मोसिस का केस था, 4 वर अनडायग्नोस्ड, और जो कुछ इस्कीमिक चेंजेस आती है ब्रेन में, तो वो भी कभी कभार रेडियोलॉजिस्ट आपको डीमाइलिनेशन लेबल कर देती है। माइग्रेन स्पॉट्स बड़े कॉमन है, PML का 1 पेशेंट था, B12 डिफिशियंसी का 1 और 1 हेडर सेल का पेशेंट था। ये हमारे पास अवेलेबल ऑप्शन है। हमारे जितने भी पेशेंट थे उसमें वी गेव ऑलमोस्ट 8 मरीजों को हम ओक्रेलिजिमेब लगा चुके हैं, और 11 पेशेंट्स को रिटेक्सिमेब ये उनके चल रहे हैं। 23 IV मिथाइलप्रेडनिसोलोन हम दे चुके हैं इस साल। एज़ाथाइप्रिन पे सिर्फ 5 पेशेंट्स हैं जो कि अफोर्डेबल नहीं होते, तो हम उनको एज़ाथाइप्रिन पे डाल देते हैं। प्लाज्मा फिरिसिस इस साल हमने थोड़ी कम कर दी है क्योंकि हमारे पास ओक्रेलिजिमेब थोड़ी सी अवेलेबल हो गई है, सो ओक्रेलिजिमेब से हम ज़्यादा हेल्प ले रहे हैं, तो प्लाज्मा फिरिसिस ओनली 5 पेशेंट्स। So this was the regional data of my hospital for the last 1 year. Thank you. I think we are short of time. Question बाद में कर सकते हैं।
Thank you very much, sir. So for the final presentation of third session, I would like to call Dr. Waleed Shahzad, consultant and head of neurology at CDA Hospital, Islamabad.
Assalamu alaikum. My name is Dr. Waleed, और we'll discuss a little bit about the symptom management in multiple sclerosis, क्योंकि बड़ी बातें तो definitely everybody knows, लेकिन जो symptoms बाकी troubling होते हैं MS के patients में, उनको भी equally इतनी ही importance है जितनी disease modifying therapy की। So this is basically the picture of Pakistan monument. हमारे पास इस्लामाबाद में इतनी चीजें नहीं है दिखाने की. It's just Faisal Mosque and monument. तो इसमें it's basically the 4 petals हैं तो वो major cultures बताते हैं और जो बाकी 3 smaller petals हैं वो minor cultures हैं and they all converge showing the unity of Pakistan. So it's a very good historic spot. Okay, Bismillah Rahmanir Rahim. So I have no conflict of interest, no financial disclosure. So objective of this presentation would be to learn an approach to symptom management in people with multiple sclerosis, emphasizing healthy lifestyles and evidence-based treatments. A step approach हम discuss करेंगे on pharmacological and non-pharmacological treatment. Symptomatic management is day-to-day experience of people living with multiple sclerosis. MS symptomatic management is as impactful to quality of life as the choice of disease-modifying therapy. Identifying invisible symptoms and symptom clusters and recognizing the impact of comorbid health conditions are key considerations when evaluating MS symptoms. Ongoing challenges in MS symptom management include a relative paucity of randomized controlled trials for commonly used symptomatic treatments. So key considerations when evaluating multiple sclerosis symptoms. So इसमें the critical step is कि आपको ये पता होना चाहिए कि ये जो symptom है ये कोई new CNS inflammation हुई है या it's because of the general medical or psychological stressor causing acute worsening of the baseline symptom, whether it is an exacerbation or a relapse या फिर pseudo exacerbation है due to some secondary cause, or maybe an expected progression of chronic symptoms. Although all 3 situations ultimately require symptomatic intervention, exacerbations may benefit from high-dose steroids, and pseudo-exacerbations necessitate searching for and treating the underlying trigger. Clinical clues help distinguish exacerbations from pseudo-exacerbations. Symptoms from MS exacerbations are generally new in character or of greater intensity, suggesting a new CNS location of inflammation, while pseudo-exacerbations result in re-emergence of the prior symptoms without exceeding the previous experience. So इस पे we will decide कि what we have to treat the patient with, and वो सिर्फ history पे पता चलेगा आपको. When necessary, MRI with contrast helps identify the true exacerbations to avoid any erroneous use of treatments. Patients with greater MS disability are particularly prone to pseudo-exacerbations as they are a risk for many common pseudo-exacerbation triggers. Just you have to think about upper respiratory tract infections, urinary retention, constipation, pressure sores, pain, and medical and dental procedures. Psychological stress, travel, excessive exertion may also worsen the baseline symptoms. Because urinary tract infections are common culprits for pseudo-exacerbations, a quick urine dipstick या urine RE will help you decide whether this is worsening of acute symptoms or the chronic baseline symptoms. Underrated and underreported multiple sclerosis symptoms. Although the definition वो यही है कि जी patient जो आपको बताएगा वो ही patient का symptom है, but sometimes कुछ invisible symptoms होते हैं that you have to dig. When unaddressed, ye invisible symptoms are more impactful in the perception of health for MS patient. Some invisible symptoms, for example, in the case of sexual dysfunction, it is recommended to first inquire about the pelvic organ concerns, bowel, bladder, then sharing the high occurrence of sexual dysfunction, which is around 40 to 90%, twice of the general population. Okay, so medical comorbid diseases and aging considerations. MS के patients को साथ में hyperlipidemia भी हो सकता है, hypertension भी हो सकती है, coronary artery disease भी हो सकती है, diabetes भी हो सकती है. तो ये सब भी impact करते हैं MS symptoms पे. So you have to be very sure कि ये symptom MS का है या कोई medical triggers बाकी हैं जो इस चीज़ को exacerbate कर रहे हैं. इसी तरह tobacco use is very bothering in again many patients, central and obstructive sleep apnea, narcolepsy, circadian disorders, poor sleep aggravates fatigue, cognitive dysfunction, depression, anxiety among MS symptoms. Okay, so common जो हम MS symptoms हैं, fatigue top पे, then we have numbness and tingling, visual disturbances, muscle weakness, balance issues, cognitive changes, bowel and bladder problems. Okay, so इसमें this is a quick table. अब जिस तरह fatigue है, so fatigue में for every symptom there are scales, they are available on the internet. आपके पास ये scale हो OPD में, you can easily apply and then find the symptom. A fatigue में the best would be the modified fatigue impact scale, and effort sleepiness scale is a very good scale. बस इसके साथ आपको एक्स्ट्रा evaluation करनी पड़ेगी, anemia को भी देखना पड़ेगा. You have to rule out any thyroid function dysfunction or the sleep studies. So fatigue के साथ ये चीजें भी आपने rule out करनी है. Then we have the cognitive impairment. For that you can use the MOGAD जो हम normally use करते हैं. For pain disability scale. For headache, मिडास स्केल इज द बेस्ट वन. इसके साथ अगर कोई सपोर्टिंग मेजर आपको रेड फ्लैग मिलते हैं तो यू हैव टू गो फॉर एन CT और MRI. ब्लैडर डिसफंक्शन, यू हैव टू यूज द ब्लैडर कंट्रोल स्केल, साथ में यूरोडायनामिक स्टडीज या इन्फेक्शियस स्टडीज कि हम ये देख लें कि सूडो एक्सेसरबेशन तो नहीं है. बॉवल डिसफंक्शन, फिर आके सेक्सुअल डिसफंक्शन है. मूड के लिए यू कैन यूज एनी एंजाइटी डिप्रेशन स्केल. एंड देन द क्वालिटी ऑफ लाइफ, द न्यूरो QOL स्केल. For the pseudobulbar effect, the एक ही scale है but it's not easily available. Autonomic dysfunction के लिए कोई scale नहीं है. Visual impairment के लिए the National Eye Institute Visual Function Scale is a very good scale. Mobility problems के लिए you can use the 12-item multiple sclerosis walking scale. Balance and coordination के लिए the ABC score. And spasticity, modified Ashworth scale. And for dysphagia, the swallow study. So all these scales are available on the internet. Okay, so for fatigue, fatigue में the most common symptom है MS में आपने lifestyle तो definitely regular exercise is always required for an MS patient. So for pharmacological treatment, dalfampridine is a very good choice, 10 milligram every 12 hours. और इसके साथ methylphenidate and amantadine is also a good option. Dalfampridine को बस अगर एक patient को साथ seizures हैं या the renal functions are not good, तो then you will not give dalfampridine. It's a contraindication. Cognitive impairment के लिए again dalfampridine is a very good choice. और इसमें जो हम normally cognitive impairment के लिए Alzheimer's में दवाइयाँ देते हैं, in MS they will not work. There is no role of memantine, donepezil or rivastigmine, which we normally see in the prescriptions. So it's just अभी तक सिर्फ dalfampridine का ही है. For depression and anxiety, serotonin SSRIs, उसमें भी ज़्यादा जो कहा गया है that is buspirone. You can try that, dalfampridine या फिर sertraline. Okay, for pain, it's the same gabapentin, pregabalin, duloxetine, lamotrigine, trigeminal neuralgia, tonic spasms के लिए carbamazepine, oxcarbamazepine. बाद में फिर transcutaneous electrical nerve stimulation you can use, and spinal cord stimulators. For headache, it's the same. The management would be the same according to the Headache Academy जो आन guidelines हैं उसके मुताबिक है. There's nothing new in that. For spasticity, baclofen, tizanidine and gabapentin, very good choice. बोटॉक्स और कैनबिस का भी बहुत अच्छा रोल है, लेकिन अब वो FDA अप्रूवल में नहीं आ रहा क्योंकि वो कग्निशन को इम्पेयर कर रहा है कैनबिस, बट इट हैज़ अ गुड रोल, इसलिए FDA अप्रूवल नहीं मिल रहा. बाकी स्पैस्टिसिटी के लिए इंट्राथीकल बैक्लोफेन पंप है, डॉर्सल राइजोटमी है. Again, mobility balance के लिए again dalfampridine is a very good choice. I'm not sure if it's available in Pakistan, but FDA approved है dalfampridine. उसके बाद जो आगे हमारे पास यूरोलॉजिकल, अच्छा इसमें जो है इसमें इंपॉर्टेंट उन्होंने ये कहा है कि आपका बेस्ट वुड बी द सोलिफिन एंड मीराबेग्रॉन, क्योंकि ये इनके कग्निशन पे साइड इफेक्ट्स कम है. नॉर्मली तो हम टॉलटेरोडीन भी डाल देते हैं, ऑक्सीब्यूटिन बी, बट इसमें जब उन्होंने कंपैरिजन किए तो दे प्रेफर कि यू यूज सोलिफिन एंड मीराबेग्रॉन फॉर द यूरिनरी इश्यूज. और दूसरा बोटॉक्स इन द ब्लैडर इज द लास्ट रिजॉर्ट. Erectile dysfunction के लिए the recommended is sildenafil and tadalafil. Both are available in Pakistan. You can use them. For mild constipation, same lactulose है, इसके अलावा polyethylene glycol है, magnesium salts हैं. Pseudobulbar effect के लिए the same that we use, dextromethorphan, quinidine, SSRIs and SNRIs. For eye movement regularities or visual acuity, as well as this one, इसमें भी dalfampridine का बहुत अच्छा रोल है. अभी लेटेस्ट स्टडी हुई है उसमें इन्होंने बैलेंस एबनॉर्मेलिटीज, अटैक्सिक और जो आई एबनॉर्मेलिटीज है उन्होंने dalfampridine का बहुत अच्छा रोल है. ओके एक्सरसाइज एविडेंस, अब तो एक्सरसाइज की भी प्रॉपर गाइडलाइंस हैं सिम्टम्स में। वो मैंने इसलिए ऐड नहीं की क्योंकि वो हर EDSS के साथ हर एक्सरसाइज उन्होंने फ़र्क बताई हुई है। यू कैन ईजिली फाइंड इट ऑन द इंटरनेट। पर जो मेजर रिकमेंडेशन है कि जी 120 to 150 मिनट्स रिकमेंडेड एक्सरसाइज है वीकली फॉर MS पेशेंट्स। दे हैव टू बी, जितना वो आप उन्हें मोबाइल कर सकते हैं, यू हैव टू डू दैट। वरना all these pharmacological therapy, every pharmacological therapy has side effects. So exercise ambulation is very important. इसमें भी kai techniques हैं, yoga techniques हैं. It's a proper exercise protocol depending on the EDSS. Non-pharmacological therapy वही gait है, gait training. डेल्फेम्ट्रेडिन पे मैंने जिस तरह बात की थी, अभी 2021 में एक मेटा एनालिसिस हुआ है जिसमें 1691 पार्टिसिपेंट्स थे जिनको उन्होंने डेल्फेम्ट्रेडिन दी है। उसने फटीग भी इम्प्रूव की है, वॉकिंग इम्बैलेंस, विजन इश्यूज, बहुत इंक्रीज वॉकिंग स्पीड दे हैड द रिजल्ट्स ऑफ दिस। Dalfampridine may also treat eye movement abnormalities, horizontal circadian pursuits, etc. Again, history of seizure में नहीं देना, and अगर creatinine clearance कम है तो these are the contraindications for dalfampridine. Baclofen and tizanidine is the drugs for MS spasticity. और बैक्लोफेन को we have to be very careful with that क्योंकि higher doses पे फिर ये cognition में issue होता है, forgetfulness, brain fog. And sometimes उसको हम हम exacerbation consider करते हैं, मगर if you taper down baclofen a little, patients get better. So you have to use baclofen very carefully. Cannabis बहुत अच्छे उन्होंने रोल देखे हैं, स्टडीज भी हुई हैं, बट इशू आ रहा है ड्राउजीनेस का और फटीग और कंफ्यूजन का। तो इसलिए FDA अभी तक अप्रूव नहीं कर रहा कैनाबिनॉइड्स को फॉर ऑल द सिम्टम्स। उसके बाद है बोटॉक्स। बोटॉक्स इज फॉर स्पैस्टिसिटी, न्यूरोजेनिक ब्लैडर, इनकॉन्टिनेंस। इंजेक्शंस आर इजीली अवेलेबल। और अब वो ये न्यू गाइडलाइंस में कह रहे हैं कि यू ट्राई दीज। हम नॉर्मली इन सारी ट्रीटमेंट्स को लास्ट रिजॉर्ट में रखते हैं, हम कहते हैं कि पहले ओरल फार्माकोलॉजिकल ट्रीटमेंट कर लेते हैं, पर दे सॉ कि उनसे ज़्यादा साइड इफेक्ट्स हो रहे हैं, एंटी मस्क्रेनिक साइड इफेक्ट्स हैं, बैक्लोफेन से कग्निशन इम्पेयर हो रही है। सो नाउ वहाँ पे दे आर गोइंग डायरेक्टली टू ये बैक्लोफेन पम्प्स हैं, dorsal rhizotomies हैं और बोटॉक्स है for the neurogenic bladder. Okay, so consider low evidence systemic therapies and high risk medical procedures. इसमें dietary supplements कोई रोल नहीं है किसी भी dietary supplements का। हम काफ़ी vitamins पे होते हैं MS के patients, सिर्फ vitamin D का रोल है वो आप सबको पता है। बाकी जितने vitamins हैं they, और काफ़ी patients they take vitamins क्योंकि उनको लगता है कि maybe it will help with the cognition या जो भी उनके symptoms हैं, but the American Academy has rejected the use of vitamins in MS. ओके सो बेसिक्स अप्रोच यही है कि यू शुड फॉलो अ स्टार्ट लो एंड गो स्लो अप्रोच। आप जितने भी फार्माकोलॉजिकल ट्रीटमेंट डिसाइड करेंगे अपने पेशेंट के सिम्टम्स के लिए, यू गो स्लो। और डोज रिडक्शंस और टाइट्रेशंस यू हैव टू सी विद द रिस्पॉन्स। अगर आपको लग रहा है कि वो साइड इफेक्ट्स दे रहे हैं, डोंट यूज देम, यू गो टू अदर एडवांस थेरेपीज। उसके बाद डाइटरी सप्लीमेंट्स हैं, इसका कोई रोल नहीं है। 80% ऑफ द पेशेंट, उन्होंने स्टडी की है कि 80% ऑफ द पेशेंट्स आर टेकिंग विटामिन्स इन MS, बट दे हैव टोटली रिजेक्टेड दिस। ओके सो मल्टीपल स्क्लेरोसिस क्वालिटी मैट्रिक्स, जब भी आपके पास पेशेंट आए पहले MRI मॉनिटरिंग करें फॉर MS की, डिजीज मॉडिफाइंग थेरेपीज को देखें, उनके साइड इफेक्ट्स को देखें। इंपॉर्टेंट इज टू लुक एट द ब्लैडर, बॉवल, सेक्सुअल डिसफंक्शन। नॉर्मली वी डू नॉट आस्क अबाउट दिस, सोशल टैबू है, बट उसका भी वो तरीका उन्होंने बता दिया कि आप पहले थोड़े पेल्विक ऑर्गन्स का डिस्कशन करके एक दो लिटरेचर बताएं पेशेंट को, देन दे विल स्पीक इट अप। बट इट इज़ अ वेरी इंपॉर्टेंट थिंग टू कंसिडर। हम नॉर्मली इस चीज़ को फोकस नहीं करते। कग्निटिव इम्पेयरमेंट आपने फिर देखनी है और फटीग देखनी है, एंड देन एक्सरसाइज एंड अप्रोप्रिएट फिजिकल एक्टिविटी का बताना अकॉर्डिंग टू द EDSS इज़ वेरी इंपॉर्टेंट। वी नॉर्मली एक्सरसाइज क्या हम नहीं बताते पेशेंट्स को, बट इट हैज़ टू बी पुट अप इन द प्रिस्क्रिप्शन। ओके सो ये सब कुछ अवेलेबल है इस वेबसाइट पे nationalmssociety.org। इसमें हर सिम्टम के आगे स्केल्स भी आपको मिल जाएंगे। यू कैन डाउनलोड देम, यू कैन अप्लाई देम। एक तो ये वेबसाइट है, और दूसरी एक और वेबसाइट है, ये मेरी वैसी नज़र से गुजरी कि दे आर डूइंग फ्री ऑफ कॉस्ट MRI इन अमेरिका, क्योंकि दे डू कॉस्ट अ लॉट। सो जो फॉलोअप हम करते हैं आफ्टर एवरी 6 months या जब भी, तो ये वेबसाइट है। इसमें अभी पाकिस्तान नहीं ऐड हुई, बाकी कंट्रीज ऐड हो गई हैं, तो यू कैन लुक दिस अप। और फ्री MRIs इस वेबसाइट के थ्रू, एंड वी कैन ऑल्सो स्टार्ट दिस अगर हम कोई भी डोनेशन प्रोग्राम है तो जितने फॉलोअप MRIs करने होते हैं पेशेंट को एंड दे आर वेरी कॉस्टली, तो इसमें उन्होंने सारी गाइडलाइंस दी हुई हैं एंड दिस इज़ वर्किंग इन अमेरिका। सो कंक्लूजन यही है कि आपने पहले देखना है कि ये रिलैप्स है या एक्सेसरबेशन है या सूडो एक्सेसरबेशन है। जितने सिम्टम्स हैं उनके प्रॉपर आपके पास स्केल्स हों, यू अप्लाई देम एंड देन यू डिसाइड द बेस्ट फार्माकोलॉजिकल थेरेपी विद मिनिमल साइड इफेक्ट्स। अपनी प्रिस्क्रिप्शन में वाइटामिन्स हमने कम करने हैं, और जब आपको लगे कि आपके ओरल एजेंट्स पेशेंट को हेल्प नहीं कर रहे तो गो फॉर द बेस्ट ट्रीटमेंट। डू नॉट बी शाय, डू नॉट बी शाय रेफरिंग द पेशेंट टू अ पेन स्पेशलिस्ट फॉर एनी इंजेक्शंस, एनी बैक्लोफेन दैट यू नीड, बजाय कि हम ओरल ट्रीटमेंट से पेशेंट्स को खराब करें। So these are my references. It's an excellent article in the New Continuum. उसमें आपको सारी एक्सरसाइज की डिटेल्स भी मिल जाएंगी, और बाकी the second article was very good. ये है तो थोड़ा पुराना बट इसमें और भी डिटेल्स हैं, मेजॉरिटी तो यही है लेकिन थोड़ी माइनर डिटेल्स आपको इसमें मिल जाएंगी. So the first two are recommended if you want to read at home. Thank you.
Any questions?
Okay, thank you.
So that's the end of the third session. For certificate distribution, I would request Professor Arsalan to kindly come on stage. Yes, sir. Dr. Haris. Dr. Irfan Khattak. Dr. Waleed Shahzad. Dr. Aisha Aslam. Sir. Dr. Meher Bano. Professor Memuna Siddiqui. Professor Tahira Aziz. Thank you very much, sir. So now we have a lunch and prayer break.
एक comment दे दूं.
जी मैम, sure.
Thank you. So just हारिस एक मासूमाना सवाल और एक comment जो you presented in your report also, और हसन ने फिर उसको we went into a shock. If I remember, you mentioned that this is going on for the last since 2021, that this Paktrims is going on, and the people present their data. So why this data is not published? I mean, people every time present it and then they don't present, then published it. तो अगर आज तक अगर like पिछले 2-3 साल का भी लोगों ने जो यहाँ present किया, and it's a very good data. See, आप लोकली जर्नल्स में प्रेजेंट लिख सकते हैं, बल्कि इवन इंटरनेशनल में, क्योंकि यहाँ का डेटा तो किसी के पास भी नहीं है. तो आई थिंक एक वो जो आप सजेशंस और वो मांग रहे थे वो ये कि आस्क दीज प्रेजेंटर्स जो यहाँ आज प्रेजेंट कर रहे हैं कि वो इसे पब्लिश करेंगे. आई थिंक करना चाहिए क्योंकि फिर वो हसान को रिव्यू आर्टिकल लिखने में भी आसानी होगी ना.
Thank you very much, ma'am. So let's meet again for the fourth session after the lunch and the prayer break.
Hello, everyone. My name is Wasim. I'm a professor. Hi, everyone. I'm Dr. Majid from St. John's Medical College, Bangalore.